Now you have is the pulmonary embolism. So whenever you encounter a patient having a deep vein thrombosis, when a thrombus is formed in the veins, after forming in the veins, it can go anywhere, right? But first it will reach to your right side of the heart. After reaching to the right side of the heart, now it can go into the lungs, right?
Right.
When it go to the lungs, it could cause the pulmonary embolism there. Okay. And I told you that you have two supply of your lungs. Remember, one is the pulmonary vessels, and second one is
Bronchial arteries.
the bronchial arteries, right? So because of the presence of this dual blood supply, even if you have an embolism in the lungs, it generally don't cause any symptom. Okay. But if this embolism is large enough, or if this embolism, it blocks the veins, in that case only you will develop all these symptoms, all this hypoxia, VQ mismatch, all this hepatic stress, everything will be developed only if this embolism is large enough to block a major artery, or this embolism is blocking a vein. Because I told you, you can have a ischemia because of two things. One is the blockage of the artery, and second is the blockage of vein, right?
Right.
So this thing can also happen. Now, when you got a pulmonary embolism, because it is obstructing the blood supply to your lungs, what you will see is a VQ mismatch. And in this VQ mismatch, the ventilation is normal, right?
Yes.
But what you will get is a loss of perfusion. So this VQ will become infinite, right?
Yes.
And what would you call this condition when the VQ become infinite?
Dead space.
Dead space. You will have a dead space because the air is present, but this air cannot be exchanged with the blood now. So this will be a dead space. Now, second thing you will develop is a hypoxemia. Of course, if you do not have the exchange of air, the gases, oxygen, in that case, you won't have the oxygen in the blood. You will develop the hypoxemia because of that. Respiratory alkalosis will develop because you're having a deprivation of the oxygen. Sure, body will try to compensate, right? And by doing the compensation, the respiratory rate will increase. When the respiratory rate increase, you will see the patient is having a hyperventilation. And because of this hyperventilation, patient will develop the respiratory alkalosis. And I told you one more thing about this respiratory alkalosis. Whenever you have a low CO2 and high oxygen, what will happen to your brain?
Could you repeat what happens when?
When you have low CO2 in your blood and more oxygen in your blood, what will happen to your brain?
Vasodilation of the brain vessels.
Vasodilation or vasoconstriction?
Constriction.
Vasoconstriction. Low CO2 means constriction, high CO2 means dilation, okay?
Yeah.
Your brain need oxygen, not the CO2, right? So if you have more CO2, vasodilation will occur to increase the blood flow to get the same amount of oxygen again, right?
Yeah.
So now you're having respiratory alkalosis, that means a low CO2. Of course, you will be having a low O2 also because you cannot exchange the oxygen as well, right?
Yes.
So low O2 will be seen in the patient's blood, as well as low CO2 will be seen in the patient's blood. Because of this low CO2, patient can even undergo the syncope, right?
Yes.
So syncope can also happen to the patient if they have this hyperventilation suddenly. Okay. Patient will get a sudden onset of dyspnea. Respiratory distress will happen. A sudden onset of dyspnea. Pleuritic chest pain can also happen. Trachypnea will happen. If this embolism is large enough, it can cause an obstructive shock in the patient also, right?
Right.
So obstructive shock can happen. Patient will undergo a tachycardia and a hypotension. Okay. So patient generally have a high heart rate. Okay, trachypnea, that means hyperventilation. Because of a blockage in the blood supply, patient can also have a jugular vein distension because the load on your right side of the heart will be increased now because of this obstruction, right?
Right.
So if the load on this right heart is increased, you can also see the jugular vein distension, right?
Yes.
But please note, because there is no inflammation yet now, the X-ray of the patient will always be normal. You cannot see anything on the X-ray. Okay. Even if you perform the auscultation, you will see a negative auscultation. No auscultation findings will be seen. Okay. Because there is no inflammation, there is no leakage of the blood from the sides. So auscultation negative, chest X-ray negative. Patient is having a sudden onset of dyspnea, having a pleuritic chest pain. He's having a shock, maybe a tachycardia, hypotension. That means jugular vein distension can be there, and hyperventilating patient. You will always suspect the pulmonary embolism. If the embolism is large enough, or you can call it a sudden embolus also, if that happens, patient can undergo a sudden death also. Okay. So because the the X-ray of the patient is negative, auscultation of the patient is negative, the only thing you can perform is the pulmonary angiography in the patient. Okay. Other than this pulmonary angiography, yeah, this is the main thing. So CT pulmonary angiography will be performed, and in that case, you will look the blood vessels. And as you can see here, this is a CT pulmonary angiography, and this is here showing the obstruction, right? This is a thrombus, or you can say the embolus, not a thrombus. This is the embolus, right?
Yes.
Appreciating.
Yes.
This kind of angiography, you will see a blockage, you will see in the pulmonary arteries. That's how you know patient is having a blockage. These are all the pulmonary arteries. Okay. This is a left side or right side?
Left.
This is left and this is right. Okay. So this is a left pulmonary artery and this is the right pulmonary artery. So patient is having a blockage clearly, as you can see. So this thing will help you determining. Now, other important thing, if this embolism happens before the death, if the cause of the death is this embolism, that means this embolism happened before the death, what you will see is a line of Zinn. Okay. You will see the alternate lines of the platelet fibrin and RBCs. So one line that is made up of platelet fibrin, another line which is made up of the RBCs. Okay. So this is a line of Zinn, and that you will see if this embolism happens before the death. Okay. So because sometimes you can have a thrombus development after that also. Okay, so this line of Zinns will help you determining whether it is a this thrombus, whether this embolus formed before the death or after death. Okay.
Why would a thrombus form after death?
Because of the status of the stasis of the blood, right?
Okay.
Yeah.
So why it
Stasis of the
lacks,
blood. Yeah.
why it lacks lines of Zinn?
Why these lines are forming?
No. I am saying why the post-mortem thrombi lacks lines of Zinn.
Because the RBCs, they have a very large weight than these platelets and fibrins, right? So they will just deposit on the base, right, of these vessels. There they can form the thrombus, but you won't see the alternate lines of RBCs and fibrins, right? Because according to the weight, they will settle down, right?
Okay, so the thrombus does not.
After the death, yeah, after the death, thrombus will be forming. But see, after that, the whole effect is of gravity, right?
Yeah.
So whatever the object is heavy, it will settle down more.
Yeah.
So at the baseline level, you will have the RBCs, then you will have platelets, then you can have the fibrin, not the alternate fashion.
Yeah. Right.
Right?
Right.
So this thing can happen. So that's why the line of Zinns, they will help you determining whether it is a pre-mortem thrombi or a post-mortem thrombi. Okay. Now, if the staff one asks you in case of pulmonary embolism, where is the defect? Whether it is a perfusion defect or whether it is a ventilation defect. So perfusion defect. Okay. It is purely a perfusion defect. Ventilation is absolutely normal. Even for the compensation, the ventilation is increased, as you can see. Because of this hypoxemia, patient is undergoing hyperventilation. So ventilation is totally normal. Patient is not having any perfusion at some area in the lung, right?
Yes.
Now, different type of thrombi can form. And yeah, in case of this thing, if you're having a VQ mismatch, if you're having this infinity, or you can say dead space, if there is a dead space, if you give a patient 100% oxygen, would it help?
Won't.
Yeah.
No.
It would not help, right?
Right.
Yes.
It will help actually. See, I told you, you have this one alveoli here, and you have another alveoli here. Okay, you have a blood supply going to this alveoli, and one blood supply going to this alveoli. If this blood vessel is now blocked, you cannot have a blood exchange in this level. Sorry, this air exchange at this point, right?
Yes.
But all of that blood must be going somewhere.
Yes.
So this blood will be diverted to the areas where the ventilation and perfusion is still normal. So more perfusion will happen to these areas which are absolutely normal, and no perfusion happen to these areas which got this embolus, right?
Right.
If they're having a normal ventilation, but the perfusion is now increased in these areas, what you will get is a VQ mismatch.
Yes.
To correct this VQ mismatch, your body will try to increase the ventilation now. right?
Right.
So that you can have a normal VQ ratio, as you can see. Yes. So if you give a patient 100% oxygen, if you increase the ventilation in these alveoli, would it help my patient to increase the oxygenation in his blood?
Yes.
Yes. So oxygenation, if you give a patient 100% oxygen, okay, it can help in increasing the ventilation in the normal alveoli. So patient can achieve normal levels again. So that is again a therapy. Whenever you encounter a patient, you suspect the patient is having a pulmonary embolism, the first thing you will do is to give the patient oxygen therapy. That could save his life, okay?
Yes.
In case of shunt, because the blood is not there at all, okay, even if you give a patient 100% oxygen, this won't help the patient, right?
Yeah.
When the shunt is there, when the ventilation is absolutely zero from the areas where the blood is going, in that case, even if you give the oxygenation in these areas, that won't help my patient, because the blood is not going to areas where the oxygen is present, right?
Right.
So for shunt, oxygenation won't help, but for embolism, but for this that space, this 100% oxygen will help. Okay.
Okay.
Can
Doctor,
you repeat the shunt part?
Yeah.
Can you repeat the part that you explained about shunt?
So you have this right heart here and a left heart here. Okay. Blood must be going from right heart and then should be entering to my left heart, right? Passing through my lungs. Yes. These are the lungs
Yes.
for saying. Now, if this blood is directly going from my right heart to left heart, even if I give oxygen to this area, can this help my blood to get more oxygenation?
Yes.
Yes or no? If this blood is not passing through the lungs at all, even if I give 100% oxygenation to the lungs, would it
No, no,
increase the oxygen level in my blood?
no, it won't.
It won't, right? So
Right.
oxygen therapy won't help in case of shunting, but it will help you in case of dead space,
Okay.
right? Because
Right.
in dead space, the blood is going to the lungs. Okay, that is for sure. Although the blood is not going to this lung, but the blood is still going to this lung, right?
Yeah.
So you will increase the oxygenation in this lung instead.
Yeah.
So that would somewhat help in attaining a normal level. Although you can never achieve a normal level, but near normal could be achieved, right?
Yeah.
So that is the idea behind it. Now any doubt?
Yeah. Got it. Thank you.
doctor, in the CT angio image B,
Yeah.
can we decide the site of obstruction? Is it more proximal or more distal?
More proximal or more distal? That's for that thing you need to know at what level you're performing the CT first of all, whether the T3 level or C, right?
Yes.
Only then you can decide whether it is more proximal or distal. By looking just at a CT, you cannot know at what level it is performed, right?
Yes, but
Or you must have a very good knowledge of the CT.
it shows that the diffuse areas are obstructed by blood flow, right? There's a large emboli.
These areas, right?
Yeah, we're not supplying a diffuse area of alveoli or large area, let's say.
Yeah, large areas obstructed with the
Yeah,
embolism, yes.
yeah, and in such a case, will the O2 oxygen also make a benefit or not?
If both of my arteries got blocked, you're asking.
Yes, exactly.
If both of my arteries got blocked, then blood is not going at all in my lungs, right?
Is that picture showing
Patient,
that both arteries, right and left side, are obstructed?
yeah, both the arteries, as you can see, is obstructed in this case.
Yeah,
Both the right as
exactly,
well as left.
exactly.
That
In
patient
such,
must be immediately died. Yeah, this
okay,
patient must be immediately die, right?
okay, but in such a
See,
case,
the
we will
cardiac
not be left.
output must be going to my left heart, right? If I'm
Sorry.
totally blocking my vessels, my blood cannot pass to the left heart. Immediate
Okay.
shock will happen to the
Yes,
patient.
yes,
If the blood is
yes.
not going to lungs at all, no matter how much oxygen you give, it won't improve my patient's condition. So
Okay.
a very narrow time period will be there. If you save the patient, if you remove this embolism, you will save the patient. If you cannot remove it, the patient will die immediately, right?
Okay. Yes. So it will die before the oxygen therapy on
Yeah,
even.
exactly.
Okay. Thanks. Okay. Okay. Thank you very much.
Now, different type of embolisms can happen in the lungs. Okay, you have the fat embolism, you have the air embolism, you have the amniotic fluid emboli, remember?
Yeah.
In the complications of the pregnancy we have discussed. Amniotic embolism can also happen, yes.
Yes.
Other embolism could be due to a bacteria. Remember the endocarditis?
Yeah.
If you have a right-sided endocarditis and the vegetations got dislodged, where they will lodge? In the lungs, right?
Yes.
If there is a tumor present, then I told you because of a tumor, you can have a hypercoagulable state. Other than that, patient can also have a sterile vegetations on the these walls, right?
Yes.
And what you will call it?
Marantic endocarditis.
Marantic.
Liebman sac. Same thing, I think.
Liebman sac. Liebman sac endocarditis, right? Where you have the these vegetations on both sides of the heart, right?
Yeah.
So Liebman sac endocarditis can happen. If that thing happened, vegetations again got dislodged, patient can have a pulmonary embolism, right? Similarly, because of the tumors, I told you patient will be having a very hypercoagulable state. Patient can have a deep vein thrombosis because of that, right?
Right.
If that thing happened, patient can again die because of pulmonary embolism again, in case of cancer. Similarly, I told you about these myxomas also, right?
Yes.
So myxomas, if well, most of the time they happen in the left side, but if they somewhat happen in the right side of the this heart, then they again can cause a pulmonary embolism also, right?
Yes.
So these are some type of embolisms you can have in the lungs. A special case for remember is the fat embolism. Whenever you have a fat embolism, that always happen because of a fracture of long bones. And the classical symptoms will be see whenever you have a fat embolism, patient will be having a petechial rash, very important. Patient will be having a neuropsychologic abnormalities. Okay. Patient will be having a hypoxemia also. So apart from the pulmonary embolism, if you encounter a patient who is having a petechial rash, along with neurological disturbances, you will immediately think about the fat embolism. Step one will give you a patient having a recent history of fracture or a trauma. Okay, they will give you a patient having an embolism. They will tell you apart from embolism, patient is seemed to have some kind of a rash on his skin. Apart from the rash, patient is having a paralysis or maybe a psychiatric abnormalities suddenly. And that's how you know they will ask you what kind of an embolism it could be. That's how you know patient will be having a fat embolism. Okay.
There is a questions like why neuropsychiatric disorder?
Maybe because all these fat emboli can even go into the brain.
Oh, so because of that they develop neuropsychiatric disorder.
Exactly. Okay. Yeah.
Yeah.
So these embolus, because you know whenever the fracture happens, all these embolus will be releasing in the systemic circulation, right? So ultimately they can go anywhere, and it is seen that most of the times they go in the brain, and when they go in the brain, you can have a neurological abnormalities because of that. Okay, so hypoxemia, abnormalities, chest pain, hyperventilation, with a recent history of trauma, you can think about the fat embolism. Okay.
Yes.
Okay. Then second, you have the air embolism, and this happens whenever you go from a high pressure environment to a low pressure environment. So on going from a high pressure environment to a low pressure environment, that is you call a decompression sickness, what will happen? You will have a formation of nitrogen bubbles in your blood. And whenever these nitrogen bloods, these bubbles formed in the blood, you will have this kind of embolism, right? Air embolism. This will obstruct the vessels. This will cause a pulmonary emboli. Other than that, I told you about this Cason's disease or a decompression sickness, that you can also have one MSK condition because of this. Any musculoskeletal condition because of this sickness, the decompression sickness.
Band and stroke disease.
Osteonecrosis.
Osteonecrosis. You can have a avascular necrosis of femur, head of femur, right? No?
Yeah.
So avascular necrosis of head of femur can also happen because of this air embolism. Remember that condition also. Okay. So you can treat this by giving patient a hyperbaric oxygen. Okay. Sometimes while cylinder light placement, while giving a patient IV, sometimes what happened, the injection might have some bubble in it, right?
Right.
And if you inject this in the patient's body, you can have a bubble in the patient's blood that can again cause this air embolism. So iatrogenic causes could be there, okay, or Casson's disease could be there. They can cause the air embolism. Other type you will have is the amniotic fluid embolism that happens in the postpartum or in the labor timings, right? Whenever the patient is in the labor or you've delivered the baby, sometimes some of the amniotic fluid can enter into the patient's blood. And if that happens, this embolism can reach the pulmonary areas. It can cause a pulmonary emboli. And I told you one more thing, that this amniotic fluid can also cause the DIC,
Yes.
Yes.
right? Because it has a why it can cause a DIC?
Tissue factor release.
Tissue factor, yes. Okay. Because it has also one more thing, not the tissue factor, one more thing in the amniotic fluid is present that can activate this pathway.
Fetal parts.
I mean, why you're having a DIC because of that?
Activation of intrinsic pathway and consumption of platelets.
You have the arachidonic acid metabolites, okay?
Yes.
So these metabolites that are present in your amniotic fluid, they are activating this pathway, okay?
Yeah.
So remember that, okay? You will have these things in your amniotic fluid that is activating the DIC. So apart from the embolism, in case of your amniotic fluid emboli, patient can also have a DIC. So whenever I encounter a female patient who just delivered a baby and now she is having a respiratory distress along with a cardiogenic shock or maybe obstructive shock, and the patient is also having a bleeding from the IV sites, from the gum, from the nose, then that's how you know that the patient is having a amniotic fluid embolism, right?
Yes.
Now, other than that, patient can also have a septic pulmonary infarction. Okay, that happens in case of endocarditis or maybe in case of septicemia. Whenever the bacteria gain access to your blood, they can go anywhere. They can go to the lungs. If they go to the lungs, they can cause a pulmonary infarction or pulmonary embolism there, right?
Yes.
So now, most of the times, because this embolism happened because of the DVT, so most of the patients, they have a history of stasis. It could be a bus driver. It could be a patient who just, landed after long hours of flight. A patient who's on a road trip could be, right? So multiple history of the stasis could be there. A patient who is in the hospital bedridden. Okay. So the staff will most often will give you a history of stasis in a patient, some kind of. Okay. And then they will ask you why the patient is having a chest pain. So the obvious answer is patient will be having a DVT, and because of this DVT, patient will develop the pulmonary embolism. Now, because of this embolism, patient, because you're inhibiting the blood supply to an organ, what will happen is infarction, right?
Yes.
So patient can also have a pulmonary infarction. And what kind of an infarction will happen in case of pulmonary embolism?
Wedge shaped.
Wedge shape, of course. What is the color? Red or normal pale?
Red hemorrhagic.
Right. You will have a red hemorrhagic infarction in that case. As you can see, this is a embolism blocking a vessel. Okay. So a red hemorrhagic infarction will be seen on the gross examination of the patient. Okay. When the patient die, of course, you will remove the lung. You will check what kind of infarction is present, what is the cause of death, and you will see patient is having a red infarction in the lungs. So that's again significant as a patient is having a pulmonary embolism. So any doubt on this topic?
No, thank you.
Okay, now you have the medicinal pathologies. Different masses can form. Yeah. Yeah. Is writing down? No? Okay. So now you have the medicinal pathologies. Okay. Multiple structures are present in your mediastinum: lungs, heart, thymus, lymph nodes, esophagus, aorta, right? Multiple structures are present in the mediastinum, right? So you can have sometimes a tumor in the mediastinum, or some kind of other mass can be forming in the mediastinum that is forming the mediastinal masses. And because of these masses, you will have symptoms accordingly. So you will have the anterior, middle, and posterior masses. In the anterior, you need to remember about the 40s, which are the thyroid, thymic neoplasms, teratoma, and the lymphomas. Okay, so whenever you have a lymphoma in the thorax region, whenever you have a teratoma, whenever you have a thymic neoplasm, whenever you have a thyroid, step 1 can ask you in what part of your mediastinum these masses are present. So it will be the anterior mediastinum. Okay.
Yes.
Then you have the posterior mediastinum in the the middle mediastinum. In the middle one, you will be having an esophagus. So if the esophageal carcinoma happens, if you got a mass in the esophagus, it will be projected in the middle mediastinum. Similarly, if some kind of a metastasis happen, it will again will go into the middle mediastinum. Hiatal hernia that you guys know. Remember hiatal hernia?
Yeah.
What is it?
The stomach enters the thorax.
Thorax. Yes. And when it enters the thorax, it will be in the middle mediastinum. Okay. And finally, bronchogenic cysts, whenever they will form in the middle mediastinum. Finally, you have the posterior mediastinum. And in neurogenic tumor, for example, the neurofibroma that is affecting your spinal cord, that will be present posteriorly. Multiple myeloma, when happen to the spinal cord, this will again present in the posterior mediastinum, right?
Yes.
Let me show you a picture from the internet that's showing the anterior middle and this posterior part of the mediastinum. Give me a second. Yeah, so this is the anterior mediastinum. Okay, this is the middle mediastinum, and this is the posterior mediastinum. Okay, this is your trachea, and what is the location of the esophagus? Anterior trachea or posterior trachea?
Posterior.
Posterior. So this is your esophagus. As you can see, this small opening here, surrounded by the muscles. This is the esophagus. Okay, and esophagus is a part of your anterior mediastinum, right? See,
Okay.
and some part is entering into the posterior one, some part is also present in the middle one. Okay, so
Yes.
as you can see now, yeah, the heart mainly is in the middle mediastinum, and the posterior structures, they include the spinal cord, right? So whenever a kind of a neurological tumor, whenever it happens, whenever a tumor is affecting your spinal cord, okay, the bones, it will always be a posterior mediastinal mass, right?
Yes.
Right.
Okay, and as you can see, the thymus will present here, Okay, thyroid, which is present anterior to my trachea, right? So thymus, thyroid, whenever a lymphoma occurs, because lots of lymph nodes are there. Okay, so they will be always present as an anterior mass. Okay, similarly for the middle one, as you can see, some part of the this esophagus lies in the anterior part. Okay, and the lower part is in the middle and the posterior part. So whenever you have a esophageal cancer, if it is happening in the upper part, okay, it could be the anterior mass. Okay, but mostly because the tumor happened in the lower part, it will be a this middle part, right? Then for the posterior part, neurological tumors and multiple myeloma again. Let me show this again, other thing. So for the antemediastinum, which is this part, okay, you will be having aneurysms, choroidal lymphoma, lipoma, teratoma, thymoma, thymus tumors. For the middle one, you will be having a bronchogenic cyst, tumors, lymphomas. Okay, vascular masses could be there. Some part of esophagus lies here, so esophageal cancers can happen here. Okay, for the posterior mediastinum, esophageal tumors again can happen here. Okay, aneurysms can happen here. Bronchological tumors can happen here. Okay, neurological tumors, multiple myeloma can happen here. Okay, so for that you need to remember all these masses. Any doubt in that part?
No, thank you.
Okay, follow the first aid here. Although different books says different thing about these masses, but I think it would be best if you follow the first aid in this case. Okay, I think UWorld also has a question on these masses. It is newly added in the UWorld, I think 1 or 2 months before. If someone encounter it, please let me know. Okay, we will discuss that. Okay.
Yes.
I had a question
Yeah.
about teratoma, in which part it lies.
In which part it lies?
Not mediastinum,
Sorry.
in which part mediastinum? Like anterior, middle, or was something
Anterior.
like that.
Anterior.
Yeah, it is anterior. I'm just saying I had that question in you word.
Okay. So you can share that question. We will discuss if there's more detail about the question present, about the explanations. Okay.
Okay, I've solved it quite earlier. Can't remember now.
You can
I will
search
check.
it. I think as there's search option for the keywords also.
Yeah. I will search it and share it in you.
Yeah. If you can find, we'll discuss. Okay. Now, second thing about the mediastinitis, which is basically inflammation of a mediastinum that can happen after some kind of a surgery. Okay. It can happen because remember the esophageal perforation, what you will call it?
Boerhaave.
Boerhaave syndrome, yes. Right. So this thing again can cause inflammation because of leakage of all these bacteria and this air inside of the mediastinum. Patient can have a inflammation because of that conditions. And before Boerhaave, what will have one more condition where you have a superficial the damage of this esophagus?
Mallory Weiss.
Yes, Mallory-Weiss syndrome. Yes, so remember that also. Okay, so this is basically the acute inflammation because after the this surgery or after the sudden rupture of the esophagus, you will have an acute inflammation. Chronic inflammation can also happen. That happens because of a fungi, that is the Histoplasma this capsulatum. Okay, which is basically what kind of fungi it is? Opportunistic, superficial, or what type of fungi?
It causes pneumonia.
It causes pneumonia. What kind of a fungi is it?
Opportunistic.
Yeah. You have superficial
Systemic.
fungi. Systemic fungi, yes. It is a systemic fungi, okay? So remember this also. Okay, fever, so the features will include the fever, of course, because it is an inflammatory condition. You will have a fever. You will have a tachycardia. Sympathetic system will get activated. Leukocytosis will happen, again, because you're having an infection in your chest. And because it is a condition of chest, you will be having a chest pain. Okay, sometimes wound drainage can also happen if it is by any surgery means. Okay, so these are the symptoms you will see whenever you have a mediastinal inflammation. Okay, not a very important topic, just know for some basics. If having inflammation, the mediastinum will be having, of course, chest pain, fever, tachycardia, wound drainage, chest pain will be there, right? Causes are important. Iatrogenic causes could be there, esophageal perforations could be there. Okay, or sometimes chronic mediastinitis can also happen. And I told you, whenever you have a chronic inflammation, you will be having a fibrosis also, right?
Yes.
So in case of chronic mediastinitis, you will be also having a fibrosis. Okay. Then you have the pneumomediastinum, which is basically the free air inside your mediastinum. See, you have multiple organs in the mediastinum, and most of these organs are filled with the air, right?
Yeah.
Now, because this air is contained in these organs, you won't call it this pneumomediastinum. Whenever any of these organs get ruptured or destroyed, and as a result, whenever the air is leaked from that organ, and now it is freely present in your mediastinum, then you will call it a pneumomediastinum. And because the mediastinum is covered by the skin, right?
Yes.
So because this mediastinum is covered by the skin, whenever you have a bubble or of air or some kind of a air in your mediastinum, you will always hear subcutaneous crepitus, right?
Right.
So subcutaneous crepitus will be there. Very important to note. Okay, when you perform the X-ray or a CT of a patient, what you will see is the free air in your neck region or in a region where the organ should be present. For example, if you see a air, normally when you see this heart, this mediastinum, what you will see it is a white out area, right? Shadowed by the heart, right?
Yes.
But if you see a air in this region, then you will know somewhat, this air is present before my heart, right?
Yes.
So again, this will help you identifying if the patient is having a pneumomediastinum. So whenever you see a air in a places where the air should not be, you will immediately know that the patient is having a free air in the mediastinum. You will perform the auscultation. On the auscultation, you will find the subcutaneous crepitus. Okay, and that's how you know patient is having a pneumomediastinum. Okay, as you can see, the black arrows, it is not much appreciated. These arrows are present here, as you can see. These are the airs which are present. The air is also present in the neck. Okay.
Excuse me.
Yeah.
How subcutaneous crepitation will be there? What is
Because air is present just beneath the skin, right?
like
Like,
so when there will be any iatrogenic esophageal or some trauma, the air will come just beneath the
see, yeah, whenever, not just about your lungs, I'm saying whenever you have a air beneath your skin due to any cause, it may be your hand, it may be your leg. Whenever you have a air beneath the skin, you will always see patient is having a subcutaneous crepitus.
that could be generalized also.
Yeah, generalized, yes. Not a specific for this condition. Whenever you have a air beneath your skin, you will
Yeah.
always have this.
Yeah. Yeah.
Okay. Okay.
I have two
Yeah.
questions.
Yes.
First one is, in FA, it is mentioned that pulmonary embolism causes electromechanical dissociation. What is it?
Yes. See, sometimes what happens is if this embolism is there and it enters the heart, because a different tissue is present, right? So this
Yeah.
different tissue might interfere with the normal electrical this activity of your heart also, because this flow of ions is there, right? And if other tissue is present, then other concentration of ions is there inside these cells, so they will interfere with this ion movement, right?
But ions are in cardiac myocytes.
Yeah, ions are in the cardiac myocyte, but this embolism can interfere with this pathway also. In the myocytes, you have the pathways, separated pathways also. Remember all this AV bundle, AV node, SA node, and then the Purkinje fibers and all these fibers, right?
Yeah, conducting pathway.
Yeah, and suddenly, because you are having a sudden blockage of the artery. So when the sudden blockage happens, a sudden load is exerted on your heart. For example, the right-sided heart. And I told you, whenever the stretching, a super stretching is or some kind of anatomical change, whenever happen to the heart, it can cause some kind of arrhythmia, right?
Yeah.
So because of these mechanisms, this patient can develop the heart failure and these arrhythmias also sometimes, right?
Uh, But what is this pulseless electrical activity? It is. Does it mean that heart is generating
Heart,
some?
yeah. Cardiogenic shock.
Okay. Cardiogenic shock is pulseless
Sorry,
electrical.
obstructive shock. Obstructive shock. Sorry, not a cardiac. Well, see, any kind of a shock can do that. Okay, your heart is quite pumping the blood, but the blood is not available for the heart, right? So how will it pump the blood if the blood is not there at all? And that only
Okay.
happens whenever you have a severe kind of a blockage, not with the normal blockage. You won't see this condition, normal blockage. If you have a total blockage of your lungs, then only you will, you can see these things. Electrical
Okay.
activity is there, heart is working, but you are not able to find the pulse, because for the pulse you need the blood, right?
Yeah.
If the blood volume is not there because of this obstruction, you cannot find the pulse. So pulseless again.
Okay. Right. Sir,
Okay.
I have another question.
Yes.
I got. I have another question. Like we say that lungs get dual blood supply from bronchial as well as pulmonary vessels. If,
Yes.
if pulmonary vessels are obstructed because of embolism, and it also has another blood supply. So
Yes.
why lungs undergo infarction?
See, I told you, only if the infarction is large enough. If this embolism is large enough, that is obstructing a major vessel. Because no matter how much this blood supply you have, you just cannot compensate for a large blockage, right?
Yeah.
So only if a large blockage is present, you will see these things. With a small blockage, you won't see any symptom at all. It will be a asymptomatic condition totally, right? And only if you block a vein, again, if you block a vein, then only you can have a, because even if a small embolism is present, if it blocks the vein, again you can have this thing, right?
Okay, so pulmonary embolism, basically we are considering veins, pulmonary veins.
Yeah, mainly veins. For the infarction especially, we are considering mainly the veins. And if the
Right.
embolism is very large, that is obstructing a very major vessel. For example, a total right-sided block or a total left-sided block maybe, right?
Yeah, right. Thank you.
And yeah, see, whenever a patient have a pulmonary embolism, they won't die because of that. Okay, because if the embolism is small or not large enough, the patient won't die because of it. It just when the patient present, they're very much in a hyperventilation state. They're very much panicked, stressed. Dyspnea will be happening to them, and this chest pain will be happening. All these things will contribute to the death of the patient, not just this embolism. Okay,
Yeah.
the patient can die because of arrhythmias, because of a heart failure, because this shock is there in the patient, right? So normally infarction won't happen. That is not a cause of that. Other things can contribute to the death of the patient in this case.
Yeah. Yeah.
Okay.
Okay. Okay.
Okay. So again, back to the topic, pneumomediastinum. I told you whenever you have a this air in the skin, you will have a subcutaneous crepitus. And one more condition where you have the air in your pleuras, what do we call it?
Pneumothorax.
Pneumothorax. Again, in pneumothorax, if you auscultate the chest, you can find subcutaneous crepitus there also, right?
Yeah.
So this subcutaneous crepitus is not very much specific from a this condition only, but it can find anywhere also. Okay, other areas also you can see whenever you have a skin, this air beneath the skin, you will always have this. Okay, so it can happen because of a sudden rupture of a pulmonary bleb. If there's a bleb in your lungs and it got ruptured, it will release all the air. Then again, you can have this mediastinum because of any kind of a damage to your esophagus, any traumatic damage or iatrogenic damage, or maybe Borhavi syndrome can also do that. Okay. So yeah, whenever this happens, patient will have a chest pain, dyspnea, voice changes will happen. Okay, subcutaneous crepitus is the important thing that you will see. Emphysema. Okay, we'll have air in these skins. Okay, so crepitus will be seen on the cardiac auscultation. And if you see the crepitus on the cardiac auscultation, because air should not be present in your heart, right?
Yes.
But you're feeling the air, on your heart, and that's how a patient is having a free air in the mediastinum. So now any doubt?
No, thank you.
Any more doubt on pulmonary embolism or dyspnea mediastinum?
No, thank you.
Just give me a second. Okay. Now you have flow volume loops. Okay. And this is basically a loop is showing here. Okay. This is the volume of your heart, lung. Okay. And this is the expiration. This is the inspiration. Okay. Now, initially, I told you if you go back, if you guys can appreciate, this is where these lungs are working, right? That part of your lung is working, right?
Yes.
Appreciate what the volume is here, 2.2 to 2.7, right?
Yes.
So this is a normal volume at which your lungs are now working, right? When you inspire the air, you will have a raise in the volume. And when you expire, you will have a less volume in the lungs, right?
Right.
So now let's go forward again. Yeah. So normally your heart, your lung is working at that point. Okay, from 0 to 6, you have a total lung capacity. Okay, from this point, which is around 2. Okay, from 2 to 6, you have a vital capacity, right? And this air, which can never be expired out, this is your residual volume, right?
Yes.
So whenever you do an inspiration, this is how the air is flowing. Okay, this is the flow rate of the air. You will have an increase in the flow rate, then you will attain a maximum point. Okay, and then you will start expiring, right? And this is the expiratory rate. So this is a normal this flow loop of a lung. Okay, if you got any obstructive disease which is obstructing the air to enter into the lungs, okay, what you will see is this condition. You will have a shifting of the loop towards the left. Okay, in this case, you will be there's an obstruction in expiring out of the air. So as a result, all of that air is trapping inside your lung. For example, COPDs, emphysema, and this bronchitis, right? You will have a trapping of the air inside the lungs, right?
Yes.
Because of this trapping, the volume of air in your lung is increased.
Right.
So now your lung is working at a higher volume, as you can see, on 8 liters to 8.5 liters even. And the minimum volume is around 4 liters, right? From 2.
Yeah.
So in case of any obstructive disease, which is obstructing the outflow of the air, you cannot have the outflow properly. In that case, you will be having a trapping of all this air inside your lungs. So you inspire normally, as you can see, the inspiration is quite normal. Okay. But at the time of expiration, the patient's expiration is not as much as, as in this normal patient, right?
Yes.
So the expiratory flow rate of the patient is now affected. Why it is happening? Because of an increase in compliance. With the increase in flow rate, you will be having a collapsing of all these air pairs, right?
Yeah.
So this is about the obstructive lung diseases. Your lung will be working at a higher volume, and this scalloping is present in the expiratory flow rate. This is very important. Whenever you see this kind of a graph showing this scalloping, you will be immediately know that the patient is having an obstructive lung disease. Okay.
Yes.
Yes.
When you got a fibrosis in the lungs, when you have a destruction of the alveoli, your lungs cannot fill with the air now, right?
Yeah.
Right.
If your lungs cannot fill with the air, your lungs will be working at a low volume now. You will be having a less residual volume, less total lung capacity, less vital capacity, right?
Yeah, the same shape but decreased
Exactly.
volume.
Same shape but decreased volumes. That's what you will see in the restricted lung disease. If less air is there, then less air will be expired out again. So everything is kind of minimized, right?
Yes.
Yes.
So if a scalloping is present, think about the obstructive disease with a higher volume. Okay, they can ask you, they will give you multiple graphs, 3-4 graphs will be given in the options. One graph will be showing a normal pressure volume loop. Okay, and this normal scalloping will be present, scalloping with the normal volumes. Some graph will be showing a less volume with this scalloping. Graph will be showing a higher volume with this scalloping. So a graph which is showing a higher volume with this scalloping will be the COPD graph. Okay.
Okay.
So remember this. Now, in case of this pressure, this flow volume loops of the lungs, in case of any obstructive lung disease, you will be having a high residual volume because you're having a trapping of air inside the lungs. Ultimately, you cannot expire out the air. Now, as a result, your expiratory capacity will be decreased, or expiratory reserve volume will be decreased now, right?
Yes.
Yes.
So this increase in the residual volume is because of decrease in the expiratory reserve capacity or volume, right?
Right.
So the capacity will be decreased, volume will be decreased. Tidal volume will absolutely be normal. Okay, you won't have any change in it in this tidal volume. The total inspiratory volume is also be decreased again. Okay, so ultimately you're only having an increase in the residual volume, okay, and a slight increase in the total capacity, but ultimately you're losing your this expiratory reserve volume or the inspiratory reserve volume, right?
Yes.
So if I draw the graph, if this is my patient's graph, okay, let me draw this. This is residual volume, for example, in a normal patient, okay, and this is my expiratory reserve volume in this patient, in a normal patient. This is a tidal volume, and this is again the inspiratory reserve volume. Okay, what you will see in case of my COPD, this reserve volume, this residual volume will be increasing too much. Okay, and uh, this uh, this volume, which is the expired reserve volume, it will be working on a higher volume, but overall the volume is decreased now, right? As you can see, the volume is not decreased,
Yes.
right?
Yes.
Again, the tidal volume will be at a higher levels, but again the same volume. But ultimately, your inspiratory reserve capacity will be decreasing. Now only this much, right? While initially it was this much, right?
Yeah.
So all this increase in the residual volume is because of compensation by the expiratory reserve volume and the inspiratory reserve volume, right?
Right.
So if you see a normal patient having a residual volume versus the vital capacity, or you can say a total lung capacity, if you see this ratio, because there is a very slight increase in the total lung capacity, but a heavy increase in the residual capacity will occur. And as a result, the overall ratio of this patient is increased. Okay.
Yeah.
So this is again a very important thing. Step one can ask you, what about this ratio? So please note, all the volumes, although are increasing, these volumes are working at a very higher volume now. Okay, but only the residual volume is increasing while the other volumes are totally decreasing. Okay.
Yes.
So there is a very important thing. If you see the expiratory flow ratios, okay, so this functional vital capacity, whenever you take a very deep inspiration, you have this tidal volume here, normal. Okay. After you expired out the air, you will see a deep inspiration. Okay. You will reach to a maximum capacity, inspiration of capacity, and then you will forcefully expire out the air till you reach to the residual volume levels, right?
Yes.
This is thing you will perform. You will check how much volume of air you have expired out in 1 second. Okay. If this is, for example, 6 liters, okay, and after 1 second I have reached to 4 liters, then I could say that I have expired out 2 liters of air in 1 second, right?
Yes.
Now at the end of expiration, I am here, and if I see this, if I exclude the residual volume from my total lung volume, can I left with the vital capacity?
Right.
Or I can say a functional vital capacity, FVC.
Yes.
So this total amount of air that I was able to expire out, it was my FVC. And what you will see in case of your obstructive lung diseases, you will be having a low ratio of this FEV1 by FVC. Okay, because this FEV1 decreased more than the FVC. Because I told you in case of obstructive lung disease, the main problem is the expiring out of air.
Yes.
Okay, so these are all the findings you will see whenever you have a patient with the obstructive lung disease. Now, second one is the restrictive lung disease. Okay, in this case, all the volumes are decreasing, right? See, all the volumes are decreasing, right?
Yes. Yes.
But the only thing that you will have is a normal FEV1 by FVC ratio. Okay, the ratio is normal or a slightly increased even because you have a dilation of the airways because of this tracheal bronchiectasis you will be having because of the fibrosis. All the airways will be dilated open. So airflow is kind of normal. It's just you're having a low volume of every air. So FEV1 is decreased, FEV is decreased, but the ratio is normal. Okay.
Yes.
So that's all the findings you will see in case of a restrictive lung disease. Now, any doubt about this?
No, thanks.
No, thank you.
Now, although as you can see here, you're having an increase in the AA gradient in case of the obstructive lung disease and in case of this restrictive lung disease, right? See, you're having an increase in the AA gradient because in case of my obstructive lung disease, I'm having a damage of septas because of inflammation, right? So surface area of contact is decreasing.
Right.
Similarly, in case of my restrictive lung disease, I'm having a fibrosis, which means I'm having a thickness of this barrier, diffusion barrier.
Yes.
So again, this thickness will cause an increase in the AA gradient.
Yes.
So in both the conditions, in COPD and in restrictive lung disease, I'm having an increase in the AA gradient.
Yeah.
Right? And I told you because the CO2 is a highly perfusion limited gas, this AA gradient won't affect the CO2 levels, right? This exchange of CO2 won't be affected much because of this, right?
Right.
So why you are having a trapping of this high level of CO2, hypercapnia in case of the COPD and these restrictive lung diseases? Why you are having them? Anyone might want to try? Although you are having a high AA gradient because of this change in this area of diffusion or change in thickness of the diffusion, so ultimately oxygen is impacted because of it. But I told you the capacity of diffusion of CO2 is about 10 times higher than that of oxygen. So this change in the barrier won't prevent the exchange of CO2. So CO2 will be normally exchanging across my alveoli and the blood. So why you're having a hypercapnia in case of COPD and restrictive lung diseases, if that is not the cause?
Because it is the regulatory mechanism of normal respiration, like respiratory centers are dependent upon oxygen, hypoxia, as well as hypercapnic
So see, you're having a
stimulus.
hypoxia. So these centers will activate your respiration because you're having a hypoxia. So again, hyperventilation will cause more removal of this CO2, right?
Yeah,
But actually, you're having a hypercapnia. So why is that the case here?
they
I
can
told you the
tolerate.
cause of this COPD. What is the reason of this COPD? Why it is happening?
Damage to septa.
Okay, damage to septa. And why this graph is working at a higher volume?
Residual volume is increased
Why this volume is increased?
because of air trapping.
Because of air trapping. Exactly. You have an air trapping. You cannot expire out the CO2, right?
Right.
Because of the air trapping in case of COPD, you're trapping all the CO2 inside your lungs. You cannot expire them out. And as a result, you're having a hypercapnia in case of my COPD. Now, what about the restrictive lung diseases? Where you're having a hypercapnia in case of restrictive lung disease?
No. No
Yeah.
hypercapnia.
And restrictive disease, there is a membrane damage. So
Okay, if the
diffusion
membrane
environment.
damage, I told you diffusion is not affected for CO2. Diffusion affected for the O2, of course, but because CO2 is a highly perfusion limited gas, so the only thing that prevents the CO2 exchange is the loss of perfusion. Okay, if there is no exchange at all happen, then only you can have a trapping of this CO2, right?
Yes.
So because the barrier is now slightly damaged, I agree with that, but still, not severely damaged that will prevent the exchange of this CO2. So still, exchange is normal. So why you're having a hypercapnia? One more try, anyone? See, because in case of restricted lung disease, yeah.
The in restrictive lung disease, the spread like the tidal volume also decrease. Like the amount they inhale the air, it's also decrease, and the timing of perfusion also decrease.
Well, the tidal volume is although decreased, but the flow rate of the air is increased. Respiratory rate is increased in these patients. Again, try to compensate for this thing. So, not
But
a very major impact.
lungs cannot expand that level so that can perfuse to all the.
Okay, there is a perfusion effect. Okay, I agree.
Yeah.
See, the actual thing is because of the fibrosis in the lungs, you're having a destruction of the alveoli. Okay. So initially, if you're having a 10 or 20 or 200 millions of alveoli, now you're having only 150 or maybe the 100 millions of alveoli, this alveoli only, right? Right. Because of this fibrosis in the lungs, because of this alveolar destruction, what you will have is
Physiological dead space.
that is space creation. Okay. You will have a shunt formation. Okay. Because of a fibrosis in the vessels, air is present, but the perfusion is not there. What you will have is a dead space, right?
Yeah.
Because of the destruction of the alveoli, totally the blood is present, but the air is not present at that level. Shunt is is happened there, right?
Yeah.
So because of this shunt, because of this dead space, you will be ultimately having a trapping of all this CO2 in the in the blood only, right? It cannot be exchanged properly, and as a result, you will be having a hypercapnia. Okay.
Yeah.
So you can write it on the FA in the obstructive lung disease and restrictive lung disease separately. In case of obstructive ones, you're having a trapping, and that is causing hypercapnia. In case of restrictive lung disease, you cannot exchange the CO2 because of destruction of alveoli and fibrosis in the lungs. These are the main causes of hypercapnia. Okay. Any doubt?
Can you repeat it briefly? Excuse me.
See, in case of obstructive lung disease, I told you the obstruction is happening in the expiration of the air, right? You cannot
Yes.
expire the air properly. You're having an obstruction. You're having a trapping of the air inside the lungs, and that's why you're having all these higher lung volumes. Because of this trapping inside the lungs, and so that you're having these higher volumes, you will also be having a trapping of CO2 in your lungs. Because of
Yes.
that trapping, you will be having a hypercapnia in case of COPD. In case of restrictive lung diseases, because of this destruction of the alveoli and destruction of these blood vessels because of fibrosis, you will be having a dead space creation, you will be having a shunt formation, and that is promoting the this hypercapnia, right? Because for a normal exchange of air, you need both the alveoli as well as the blood vessels present, right?
So it's again a membrane issue, a diffusion issue.
Diffusion issue, you cannot say it's a diffusion. You see, if there is an intact alveoli present and an intact endothelium is present, then you will have a normal exchange. Okay.
Yes.
But if you're not having the alveoli or you're not having the blood vessels, then you have nothing to exchange there, right?
Okay. You mean
So
that
diffusion, the
will not
diffusion is normal. Yeah. The diffusion is normal. It just you cannot exchange because you're either lacking the alveoli or you're lacking the blood vessel at at the sites. Okay.
Okay.
If you have a damage to the barrier, but you have
Okay,
both the
okay.
alveoli as well as the blood vessels impacted, then you will have a normal exchange of CO2. Okay. Now, one more concept for this interstitial lung diseases or the fibrosis, which is a tranquil sorry, just give me a second. There is a the traction bronchiectasis. What happens is, because of this fibrosis, whenever the fibrosis happens, you will see the contraction of the wounds normally, right? If you guys remember general pathology, wound healing, I told you whenever you have a fibrosis or you have a normal wound healing, you will see a contraction in that, right? Because of this myofibroblast and other cells, and and these fibers also, right? Similarly, whenever you have a fibrosis in the lungs, because of this fibrosis, you will have a traction bronchiectasis. Because of this fibrosis, they will contract, and because they contract, they will cause a dilation of the airways. So you're having a destruction of the alveoli, you're having a destruction of the whole lung parenchyma, but all these airways will be dilated in case of your pulmonary fibrosis, and that's what you call a traction bronchiectasis. Okay.
Yes.
So if you do a CT or MRI of a patient of, just give me a second. If you do a CT or MRI of a patient having this interstitial fibrosis, what you will see is a dilated airways along with fibrosis in the area, right?
Right.
And because these airways are dilating, these patients won't see much resistance in the airflow, right?
Right.
And as a result, that's why these patients will be having a normal expiratory ratios, right?
Yes.
Because of this condition only. Okay, so remember this also. Now, because of this fibrosis, you're having a high elasticity in the lungs also, right?
Yes.
So the elastic recoil of the lungs is also increased. Okay, and again, you're having a widening of the airways. Okay, so resistance ultimately for the airflow is totally decreased in case of my interstitial fibrosis, and that is again promoting a high expiratory flow rate. Okay.
Yes.
Now, one thing I told you about the carbon monoxide, that it is a diffusion limited gas.
Yes.
If you're having a damage in this, in your diffusion membrane, then you will have a less diffusion of carbon monoxide,
Right.
the DLCO, remember? So because of this fibrosis, you will be having a low DLCO or low diffusion of the carbon monoxide. So a DLCO is a test that you will check for the diffusion of the gases, okay? If you're having a low diffusion, that means you have some kind of a damage with your barrier. If you're having a normal diffusion, that means your this barrier is totally normal, okay?
Yes.
So now ask me a doubt if there is.
In case of restricted lung disease, why there is increase in FEV1 by FVC ratio?
See, you're asking why this FEV1 is increased.
FEV1 by FVC ratio is increased, yes.
Yeah, see, what happens is, I told you, because of a dilation of the airways, the resistance to the air is now decreased. If the airflow does not feel any resistance, it can easily go in and out.
Yes.
That's why you're having a normal or increased level of this expiratory volumes. Okay, this is an expiratory volume in 1 second, and this is a total expiratory volume, right? You're having a normal expiration. The volume is decreased, but the flow rate, because it is normal, okay, you will be having a normal ratio. That's why, right? Or maybe increased even. Is that what you're asking?
Yes. Normal because both of them are increased, but why increased?
Both of them are decreased. Volume is decreased in both of them.
Mm-hmm. But
Okay, this is about the volume. This is about the volume. But the flow rate is kind of constant, you can see. Decreased, but the ratio is constant for both of them.
okay.
Because we're having a less airways now, less alveoli are present, less parenchyma of the lung is available for the exchange. So ultimately, volume, as you can see, is decreasing. Okay, less airways are there, so flow rate is kind of decreasing, but the ratio will always remain same. Okay, because the resistance is decreased because of a air widening, this airway widening. Okay.
Okay.
And now see, as you can see, in case of my COPD, the resistance to the airflow is increasing, right?
Yes.
And in case of my this fibrosis, the resistance to my airflow is now decreasing.
Yeah.
Right? So you need to know two things. One is the respiratory rate. Whenever you increase the respirations, what you will see is the increase in the resistance to the this airflow. Okay.
Right.
Now, if you increase respirations, that means you're increasing the resistance to the airflow. And second is the depth of the inspiration, because your lungs have an elastic recoil, right? So they
Yes.
can expand up to a certain limit only. After that, you cannot expand your lungs, right?
Yes.
Yes.
So among my COPD patients and these fibrosis patients, what patient can expand their lungs much?
COPD.
COPD patients, right? Because they have a this recoil is very less for these patients, right?
Yes.
So because these patients are having a very less recoil, but a higher resistance to the airflow because of loss of this distraction, this bronchiectasis, okay, and a loss of collagen fibers in between my septas and all these things, okay, these airways are now collapsed. So airflow resistance is very high in case of my obstructive lung disease, but the elastic recoil of lung is very low in case of my COPD patients. So these patients will have a low respiratory rate, but deep breathings. Are you getting my point?
Yes.
I told you for the airflow resistance, you need the respiratory rate. If more rate is there, more resistance will be there. If less rate is there, then less resistance will be there, right?
Right.
These patients have a very high resistance already. So if they increase their respiratory rate, they will face more resistance, right?
Right.
That's exactly not their body want. But because they're having a very low collapse of, because they're having a very low elasticity of the lungs or a very low recoil of the lungs, they can expand their lung to a higher volume, right?
Right.
So they can have a deep breathing. So to maintain the minute volume, they will increase their tidal volume, but decrease their respiratory rate.
Yes.
So whenever you encounter a patient having a COPD, you will always see that these patients are having a very deep breathing, but a very decreased respiratory rate. Okay,
Yes.
bradypnea with a very deep breathing will be there in case of COPD. In case of my fibrosis, because they have no problem with this airflow resistance, it is very extremely low. So they can have a very high respiratory rate, but they cannot expand their lung to a higher volume. As a result, the tidal volume of these patients is decreased. In order to maintain a minute volume, their body will increase the respiratory rate. So whenever you encounter a patient having an interstitial lung disease, you will always see patient is having a shallow breathings, but a very high respiratory rate. The trachypnea will be seen. So a rapid shallow breathing in case of interstitial lung disease.
Yes.
And slow deep breathing in case of my COPD. Any doubt, please ask.
No, thank you.
Okay, so remember
Here,
these two. Yeah.
could you please zoom in these pictures?
Yeah.
So here the like in obstructive lung disease, the damage of alveolar wall like it is dilated. Am I right?
Yes, they're dilated. Multiple. See, the multiple these alveoli, they combine to form one. Not just dilated. They're combining to form one.
Because it tests. Okay.
Yeah. Because of a destruction of septas in
Examining
between. You're asking that all the surface area is increasing. You're saying, right? That might be your doubt. See,
Hmm.
surface area you will calculate with the help of these lines, right? You will see this area of this alveoli and this area of this alveoli, right? But now what is happening that this area of this alveoli and this area of this alveoli is now merged together, right? So loss of this area is happening.
Yeah.
And as a result, that's why you're having a loss of surface area in contact with the vessels. Okay, they were supposed to be two alveoli, but they're merged together. Okay. Now doubt?
Sorry, my internet is poor. Sorry. Okay, thank you.
Okay. So let's discuss the obstructive lung diseases. Okay, I have told you in case of these diseases, you're having an obstruction in the airflow. As a result, you will be having a trapping of air inside the lungs. Because the air is trapping inside the lung volume will increase. And what you will see is the hyperinflation of the lung. Because of increase in the gases inside the lung, you will see the hyperinflation. What is the normal expansion of your lungs? At what rib level?
At what?
At what ribs level or intercostal level you have your lung expansion normally?
Right.
7th or 8th rib, right?
Yes.
But because of this hyperinflation, these patients can have a lung expansion up to 12th rib or even crossing the 12th rib. Okay, so if you
Okay.
perform the X-ray of these patients, in a normal person, what you will see, the lungs are ending at a, at a rib level of this 8th or 9th maybe last, right? But in these patients, their lungs will be ending at a 12th rib. Okay, so this is known as the hyperinflation that you will see in these patients. So that's happened because of a air trapping. Okay, now when the patient try to expire out, they will have a collapse of their these airways. The airways will close, and as a result, patient will be having a high functional residual capacity, high residual volume, a high total residual capacity. But please note that the increase in the residual volume is more than the increase in the total lung capacity, and as a result, you will be having a more ratio. Remember.
Yes.
And all this increase in the residual volume is because of decrease in the expired reserve volume and the inspired reserve volume, right?
Right.
So they will compensate for this increase in the residual volume ultimately. You'll be having a decrease in the airflow. So a low airflow or a low volume of air will be expired in 1 second, and the total amount of air that will be expired in a total expiration will be decreased again. Ratio is also very decreased, and that is a hallmark feature of COPD. Okay. Patient will be having a VQ mismatch. And now, because they have a trapping of air, these patients must be having a high ventilation, right?
Yes.
So high ventilation, but a normal this perfusion or a low perfusion, because ultimately the surface area of contact is not decreasing, right?
Right.
So high volume, sorry, this high ventilation but low perfusion. So ultimately they will have an increased VQ mismatch. Okay.
Yes.
Now, because these patients are having a hypoxic condition because of this air trapping, because of this high CO2, these patients are having a hypoxic environment, right? They cannot exchange the air. Because of this, patient would also be having a hypoxic pulmonary vasoconstriction.
Yes.
Now, because of this hypoxic pulmonary vasoconstriction, chronically this condition can also lead to the right-sided heart failure.
Yes.
So these patients can also have a the chronic cor pulmonale, or these patients can also have a pulmonary hypertension, right?
Right.
So this is the other finding you will see. Now, COPD includes two diseases. Although all of these diseases which are listed here, these are the obstructive lung diseases, but the COPD especially includes only two diseases. One is the bronchitis, the chronic bronchitis, and second is the emphysema. While the asthma and other diseases, the bronchiectasis, they are included under the obstructive lung disease, but they are not the COPD, okay?
Yes.
Now, because of the hypoxia, what other findings systemically you will see? You will see an increase in erythropoietin, right?
Right.
So these patients can also have a high hematocrit. Okay. Now, see what happened, because you need to remember the 2-3 things, some sounds about your lungs. You will have a rhonchi, you have a wheezing, and you have a crackling. 3 type of sounds in the heart. Okay. Sorry, in your lungs. Okay. Crackling happens whenever a portion of the airways forcefully open now. Okay. That portion of airways closed. Okay. It's collapsed. And you are forcefully opening that area. When that area is being opened, it produces a sound, and that is known as a crackles. Okay.
Right.
So in these patients, because their airways collapsing on expiration, when they inspire, their airways will again open.
Yes.
While opening, they produces a sound, and that you call it a crackles again. So these patients will be having a inspiratory or expiratory crackles.
Inspiratory.
Inspiratory crackles, because you're opening the airways at the time of inspiration, right?
Yes.
So one thing is the inspiratory crackles. Now, second thing, you have the wheezing. Now, see, just like in case of your heart, you have a murmur whenever the passage of this blood is decreased, right? Whenever you have, some kind of this atherosclerosis that is decreasing the lumen size, you will see that a patient is having some kind of a murmur there, or some kind of a sound there, abnormal kind of a sound, right?
Yes.
Similarly, in case of my lungs, whenever the inflammation of my these airways happen, and as a result, because of the hypertrophy, the lumen size of these airways is decreased, what you will see is a sound. You will hear a sound on both the inspiration as well as the expiration, and that you will call it a wheezing. Okay.
Yes.
So wheezing happened because of a narrowing of the airways, and most oftenly you will see the wheezing on the expiration. Okay, you can see the wheezing on inspiration also, but most often you will hear that in the expiration only. Okay.
Yes.
Now the third sound, which is a rhonchi. Okay, see, whenever these airways is filled with the mucin or any kind of a fluid, when the air passes through it, it will again produces a sound, and that sound is known as the rhonchi. Okay. So whenever you have an excess mucus production in your lung, in your airways, you will see the rhonchi sound. Is that okay?
Yes.
So 3 sounds again: crackles, wheezing, and rhonchi. Any doubt in these 3 sounds?
No, thank you.
Because for the next 3-4 pages, you will see only these sounds are very important. You will see some patients are having a rhonchi, some patients are having a wheezing, some patients are having a crackling. So you must know why this crackling, wheezing, and rhonchi is happening. Okay.
Yes.
Now, I think we should take a short break and then discuss further about this COPDs. Okay.
Yeah,
Okay.
thank you.
Someone was eagerly waiting for the break. Okay, again. So first you have is the chronic bronchitis, and what does it mean by the bronchitis? This term,
Inflamed bronchi.
inflamed bronchi. So you're having an inflammation in the respiratory passage, right?
Yes.
Does it mean having inflammation in the alveoli?
No.
No. So in case of chronic bronchitis, you're having inflammation only in the major respiratory tracts, not the alveoli. It's the primary bronchioles, secondary bronchioles, tertiary bronchioles, bronchis, bronchus, right?
Yes.
So it is an inflammation of the bronchis without the alveoli. Okay. If you have the involvement of alveoli, you will call it emphysema. Okay.
Yes.
So now, because you're having an inflammation in the bronchioles, you will be having the hypertrophy of the bronchioles also, right? Because it's a chronic inflammation.
Yes.
Right? All these inflammatory material will be present, hypertrophy of the mucosa will happen, right? So ultimately you will see some wheezing, right? Because of that.
Yes.
Yes.
Now, second thing is the crackles. And how does a crackle produce?
Opening of the small.
Opening of the passage of the respiratory tract. So because of the inflammation, all of this elastin is getting degraded or damaged, right?
Yes.
So because of this loss of elastin, you will lose the structural support kind of, right? So the compliance rate of the lungs again will be increased, and as a result, when the patient expire out, what will happen? Collapse of the airways will happen. And when the patient again inspires, these airways will again forcefully open, and that will produce a sound known as the crackles, right?
Yes.
Third thing is the cyanosis. Okay, I told you in case of this condition, in case of COPDs or any kind of this obstructive lung diseases, what you'll be having is the hypercapnia, right? And that is because of the CO2 retention. Other thing is, because of a damage, you will also be having a shunting in case of the this chronic bronchitis. And what is shunting means?
Blood goes from the right side to the left side without oxygenation.
Yeah, the blood is flowing, but there is no air present to exchange. Because of a destruction of the alveoli again, okay, patient can also be having a shunting because the contact area with the alveoli and these vessels will be decreasing. So because the contact area is decreasing, patient can also be having a shunting. Hypoxemia will happen. Dyspnea will happen to the patient. Patient will be having a respiratory distress. Okay. CO2 retention will happen. And because of this hypoxemia, patient will also be having a secondary polycythemia, right?
Right.
Yes.
So when you encounter a patient with chronic bronchitis, they will be having a wheezing, respiratory distress. Okay, they will be having a crackles on the auscultation. These patients will appear blue because of the cyanosis, because of the shunting. These patients will appear blue, and that's why you call them blue bloaters. Okay.
Okay, doctor, you mean by shunting that the blood will return to the heart into pulmonary veins deoxygenated,
Yeah.
right?
See, normally the blood flows from right side of the heart, then to the lungs, oxygenated, and then to the left heart. In case of my shunting, blood is going to the lungs or might not be going to the lungs, but it is not oxygenating because there is no air present in that part of lung for exchange.
Yeah, it is the normal pathway. It just that's not deoxygenated now.
Sorry, again, please. What
It is
was
in
it?
that in its original flow, its original pathway. It is just unoxygenated.
So I couldn't understand you.
I
If you can please
mean
type
that
in the chat
the blood
that the blood.
will flow.
Yeah.
The blood will flow in its original flow pathway, but it will be deoxygenated. Only that. What does shunt mean?
Blood won't be oxygenated. That was shunt mean.
Okay.
Okay. Blood is going to the normal pathway, but it's not oxygenated.
Okay.
Okay. Because you
Okay,
need
thank
both the air, you need the alveoli, and you need the blood vessels to be in a contact for the air exchange, right?
Okay.
If that doesn't happen, if the air is not there, but the blood vessels are there, that will cause a shunt.
Okay.
Any more doubt?
No.
In
thanks.
bronchitis,
Yeah.
alveoli are normal, right?
Bronchitis.
Bronchitis.
Bronchitis is what?
In chronic bronchitis, alveoli are normal.
Alveoli are normal, yes.
So why there is shunting?
Because of a damage to the blood supplies will happen. And please see, whatever happening is here, in case of your bronchitis, because of damage of these pathways, the flow of the air is not damaged, right? You cannot have so even though your alveoli are normal, the air in the alveoli will be traveled by these pathways only, right?
Right.
So if these pathways are not working properly, if they're getting damaged, how can you have the air inside the alveoli? You won't have it, right?
Okay, like less oxygen will go to the lungs.
Exactly. Less oxygen will go to the lungs. See, the
Okay.
airways getting narrower, narrow passage will be present. Plus, we'll be having a collapse of the airways. Plus, we will be having a very mucus flex in the, in these airways. A distraction of these airways will be happening. So all this will prevent a normal passage of this air from outside environment to the alveoli, right?
Okay, thank you.
Okay. So, so the wheezing will be there. You will have a patient having a respiratory distress. These patients will be having a dyspnea. Okay, you will see that the patient is also having some kind of a sound on the expiration, that is a wheezing. When you auscultate, you find these patients are also having crackles. Bronchitis can also be heard because of mucus pluggings. Okay, patient is also having a cyanosis, and that's why you call them the blue bloaters. Patient is having a high level of CO2, hypercapnia. Patient is also having a polycythemia. That's what you will see in the finding of the patient. Okay. Now, other thing, the pathology will be having a hyperplasia and hypertrophy of the mucus secreting glands. And what are the mucus secreting glands?
Goblet cells.
The goblet cells or the submucosal glands, right?
Yeah.
So two you have, one is the goblet cells and second are the submucosal glands. So one thing you measure is the Reed index. In the Reed index, you will measure the thickness of these mucus glands with a total thickness of this wall of my tract. So on the tract, you are having epithelium first, then the subepithelial layer, and finally you're having a smooth muscles and all these, this cartilage and all, right?
Yes.
So in case of your Reed index, what you will see after epithelium, you have the subepithelium, right?
Right.
So whatever the thickness of, is occupied by this mucosal gland divided by the total thickness of this subepithelial layer, you will call it a Reed index.
Yes.
Okay. So between the epithelium and the cartilage, you have the subepithelial layer, right? That is a total layer. out of that layer, how much area is occupied by this mucosal gland, how much thickness is occupied by this mucosal glands, you will call it a read index. And what you will see, because of the hypertrophy of these mucus secreting glands, in case of this chronic bronchitis, patient will be having a very high read index. Okay.
Yes.
Now, because the alveoli are normal, okay, blood vessels are kind of normal, you will be having a normal exchange. If the air reaches the alveoli, you will have a normal exchange of that air. Okay.
Yes.
So again, the DLCO of these patients will be normal, right?
Right.
So what is the diagnostic criteria? Patient will be having a productive cough for more than 3 months, okay, and for 2 consecutive years. Okay, so patient will be having a history of very chronic cough. They'll be having this problem for more than 2 years, and at least for more than 3 months in these 2 years, patient will be having a history of cough. That's how you know this patient is having a chronic bronchitis. Okay.
Yes.
And because it is kind of an inflammatory condition, so you'll be having a damage of cilia also, right?
Right.
If that cilia is got damaged, any of that particulate matter can reach to your alveoli
Yes.
and can to your deeper areas of the lungs also. So a patient can also have a recurrent upper respiratory tract infection also.
Yes.
Okay, so this is again very much common. These patients can again have a history of recurrent upper respiratory tract infections. Okay, along with this dyspnea and cyanosis and all these things. That's how you know that the patient is having a chronic bronchitis. So now you know the presentation of the patient, right?
Yes.
A chronic respiratory distress will be present, cough will be present. Okay, sometimes even a chest pain could be there. Okay, cyanosis, bluishness of the body will be there. Okay, and the patient will be having a recurrent history of upper respiratory tract infection. That's how you know patient is having a chronic bronchitis. Any doubt, please ask.
No, thank you.
Now, the second thing is the emphysema. Second type of COPD, which is the emphysema. In case of emphysema, you're having a damage in the alveoli directly. And as a result, the surface area of contact of the blood vessels and the alveoli is not decreasing, right?
Right.
And again, because of this thing, patient will be having a emphysema. That's why. Okay, now, what are the findings you will see in a patient? Well, first thing, symptoms. Let's talk about the symptoms. What symptoms patient will be having? Patient will be, so first of all, having a history of smoking, because a major cause of this emphysema is smoking. Okay.
Yes.
If you encounter, and please note, patient must be having a history of smoking for more than 20 years. A chronic smoking history is required for having this emphysema. So only you will see this condition in a patient having an age more than 40 years, generally. You won't see this condition in a young patient, okay?
Yes.
Emphysema can also happen in the young patient if they're having any genetic problem with them. For example, the alpha-1 antitrypsin deficiency, right?
Right.
With this alpha-1 antitrypsin deficiency, you are having a loss of inhibition of the inflammation. As a result, a chronic inflammation will be there in the alveoli that damages the alveoli, causing the emphysema. Apart from that, in the lungs, this alpha-1 antitrypsin getting trapped inside the cell, causing the this liver damage also, right?
Yes.
So patient will be having a hepatitis as well as this emphysema. You will think about the alpha-1 antitrypsin deficiency, and these patients are having the early emphysema. They will be having a history of smoking for only 1 or 2 years, or maybe 3 or 4 years. Only after such a smoking patient is having emphysema, very young patient, you will only think about the alpha-1 antitrypsin deficiency. While a sporadic case that is happened due to the smoking, it will always present in a patient having an age more than 40 or 45 years, okay?
Yes.
So an old age patient who is having a history of smoking for more than 20 years, now the patient is presented to your department with a history of, just give me a second. Yeah, back again. Okay, so you will get a patient who is having a age more than 40 years, having a smoking history for more than 20 years, And now the patient is presenting to you with a history of shortness of breath and cough also. Whenever you see this kind of a presentation, a chronic history of smoking with shortness of breath and cough, okay, you will think about the emphysema. Okay.
Yes.
So these are the major 3 hints you will get in order to get the emphysema patient. Now, again, when you encounter these patients, you will see the examinations. Okay. The first thing you will perform is the X-ray of the patient, right?
Yes.
On the X-ray of the patient, you will see the hyperinflation. And I already told you what this hyperinflation means. Normally, you have a lung expansion up to 7th or 8th rib only, right?
Yes.
Yes.
full
But in these
hyperinflation.
patients, you will see the lung expansion up to 11th or 12th rib. And if you
Yes.
see a floating rib in the X-ray of a patient, if you see this floating rib in the X-ray of a patient, you will immediately know that the patient is having a hyperinflation. That means it is a case of COPD. Okay.
Okay.
Yes.
Other finding is on the X-ray, you will see the flattening of the diaphragm. Normally, I told you the diaphragm is having this kind of a shape, right? This kind of a dome shape.
Yes.
Okay. So this dome shape of the diaphragm is lost and the diaphragm is getting flattened like that. Okay. Or maybe like that even. Horizontal totally, right? So this kind of a flattening of the diaphragm is seen on the X-ray of the patient. Okay. Other thing is the hyperlucency. Okay. What happens is generally when you perform the X-ray of a patient, you can see the lung markings also, right? Lung markings, ribs, and other, the blood vessels and other things also, right?
Yes.
In these patients, the radio marking will be decreased. Okay. And that's what you call is the hyperlucency. Okay. So lung field lucency will be increased. That means you will see more blackish lungs in the X-ray. Okay. More black region of the lungs will be seen. Okay.
Yes.
Other thing is the narrowed mediastinum. I told you the area which is occupied by the heart in the central portion of the X-ray, you will call it a mediastinal portion, right?
Yes.
So you will see the patient is having a very narrowed mediastinum in case of the COPD or this emphysema. Okay.
Yes.
Now, laterally, when you see the patient, you see that the patient is also having an increase in the anterior posterior diameter. Okay, so the AP diameter of the patient is increased, and as a result, you will see the barrel-shaped chest in the patient also.
Okay.
Okay, now because their airways is closed, whenever they expire, okay, they need a forceful inspiration, right?
Yes.
So they will do the inspiration with the help of lips. When they got an acute ataxia, a patient is having a chronic emphysema, but they are not always in the attack, right?
Yeah.
When the patient is having a chronic emphysema and they suddenly got an attack of this emphysema, they're having a shortness of breath, they are having a very increase in the cough count of the patient. Okay, the cough number is increased, number of times he coughs increased, amount of the sputum in the cough is increased again. So whenever you see the exacerbations of this emphysema, then only they will have this this lip breathing. Okay, not every time they have this. Only when they have the attack of this emphysema, when they got this attack of the emphysema, they will have this pursed lip breathing. Okay.
Okay.
Okay. Yeah.
So these are the X-ray findings you will see on a patient that is having a emphysema. Any doubts?
Yes. While there is air trapping, why the airway will collapse after expiration?
Because of the inflammation, you're having a loss of elastin. And I told you require the elastin to maintain the structural is normal in the tissues, right?
Yes, I know that. I mean, with COPD, we say that there is an air trapping, right?
Yeah, there's a
And
yeah, of course.
that's in both inspiration and expiration supposed to be, right?
See, in case of expiration, I told you if you go back, we have described two phenomena in which you're having. See, let me show you. Yeah, remember this inspirated stridor and the expirated stridor?
Yes.
I told you on the case of expiration, the pressure inside this thoracic cavity is increased. While in case of inspiration, the pressure inside the thoracic cavity is decreased. So this will prevent, whenever you have an increased flow, the collapse will be there. But due to this this decrease in the pressure in the thoracic cavity, this will prevent the collapse of this airways. at the time of inspiration. But at the time of expiration, because the pressure on the outside is also increased, then you will have the collapse of the air, these airways, right?
Yeah. Yes.
Is that okay now?
Yes.
So because the pressure inside thoracic cavity is increasing at the time of expiration, more pressure will be exerted on the airways, and that will cause the collapse of the airways, right?
Okay. Yeah. I mean that you mean that even in COPD, the expiration will get all of the air out, right?
Yeah.
Okay. Okay. Thank you.
Just a second again. Okay, so that was the symptoms you will see in a patient that is having a emphysema. They will always present you with a shortness of breath. Wheezing sometimes could be there if you got a both emphysema and bronchitis at the same time. Okay, wheezing could be there. Patient will be having a shortness of breath. Cough will be there, which is productive with the sputum, right? A productive cough will be seen. That means cough with the sputum is there in the patient. Okay, and that's how you know patient could be having a emphysema. You perform the X-ray of the patient. Okay, so when will you say the patient is having a exacerbations? Whenever you see the patient is having an increase in the dyspnea, increase in the cough, when the patient suddenly have a change in the sputum color. Okay, when the patient started having a prolonged expiration, when the patient is having a pursed lip breathing, when the patient's on on the X-ray is showing you a flattening of the diaphragm. Okay, and the patient is also having a high CO2 levels. That's how you know that the patient is having a attack of the COPD, right?
Yes.
In
Yeah.
between these
These
attacks, the
symptoms
patient
are
will
not
be
found.
no symptoms are not always throughout present. Only at the time of attack you will these you will get these symptoms, right?
Okay. Okay.
Patient can
Okay.
have a history for like 5 years or 6 years, but not every time they have this dyspnea present, right?
Okay.
Only at the time of attacks you will see the patient is having this shortness of breath, cough, and wheezing and all other things.
Okay.
And step one can also ask you what are the cause of the exacerbations of the COPD. So the most important cause are the viral ones: rhinovirus, influenza virus, parainfluenza virus. These are the three most important viruses that can cause the exacerbations of the COPD. The most important one is the rhinovirus. Even a normal cold in these patients, the rhinovirus is causing normal cold, right?
Okay.
And which group this rhinovirus belongs?
Picorna.
Picorna
Picorna.
family. Yes. So the patient got the exacerbations of the COPD. Other thing is bacterial infections, Haemophilus influenza, Streptococcus pneumoniae, Moraxella catarrhalis. They can cause these exacerbations in the COPD. Air pollution can cause it. In the cold, you have more attacks than in the warmth. Okay. Any kind of a pulmonary embolism, it happens, it will cause the exacerbations of the COPD in these patients. Is that okay?
Yes.
So you have encountered the patient having an exacerbations of the COPD. You have performed all the X-ray in the patient. Okay. Now, what about the biopsy? What you will see on the biopsy of the patient? You will see the excessive neutrophils and the macrophages in the alveoli, right?
Yes.
And these neutrophils and macrophages, because what is happening because of a smoking, this smoking causing a damage to your the cilias, right? So now
Yes.
all these particles can reach to your alveoli. And I told you, whenever a foreign body reaches the alveoli, macrophages and neutrophils will get activated against it, right?
Yes.
So when they get activated, they will release the elastases. And when the elastases got released, they will cause the damage of the elastin. And that will again causing a loss of elastin and high compliance, collapse of the airways, right?
Yes.
So note this, these two type of cells are very much important in neutrophils and macrophages. They are ultimately causing, the damage in this COPD. Okay. And lymphocytes also take part in case of emphysema. And please note, it is the CD8 lymphocytes, not the CD4. This is a very important thing. Okay. Explanation, I really don't know why this CD8 is there, why not the CD4. Okay. But ultimately, instead of CD4, you are having a CD8 lymphocytes in the biopsy. Okay.
Okay.
You must know this fact also. Step one can ask you what cells could be there in case of COPD. So neutrophils, macrophages, and CD8 lymphocytes. These are the three important cells which take part in the pathology of COPD. Okay, now you have two types of COPD. One is the Santi-SNR type, and second is the Pan-SNR type. In the in case of Santi-SNR type, which is generally happen because of a smoking, the central portion of the lungs got destroyed. In case of Pan-SNR type, all of the portions got destroyed. As you can see, in case of Santi-SNR, only the central portion of the alveoli, okay, it will be destroying. But in case of Pan-SNR, all of the alveoli are getting destroyed, right?
Yes.
Santi-SNR happened because of the smoking, because smoking first, all of these particles with the smoking, they first lodge in the central portion, the proximal portion, right?
Right.
While the Pan-SNR type will happen in case of alpha-1 antitrypsin deficiency, because in that case, you will be diffusing, you will be diffusely losing the capacity to stop this inflammation, right? So all of these alveoli will suffer because of that. Okay.
Yes.
So Santi-SNR is smoking, Pan-SNR alpha-1 antitrypsin deficiency. Other than that, as a complication, patient can also have an emphysematous bullous, where you have a balloon-like formation in the lungs. And if the bullous get ruptured, what you will see is a pneumomediastinum, right?
Pneumothorax.
Pneumothorax will also, pneumothorax can also be happen. Pneumomediastinum can also be happen.
Yeah.
Okay. If a subpleural bulla got ruptured, subpleural, if this bulla got ruptured, in that case, you will get the pneumothorax.
Right.
Okay. So again, complications, which is a bulla formation that can again cause a pneumomediastinum, or it can also cause a pneumothorax. Okay. Because of loss of elasticity, patient will be having a very high lung compliance. And that is because of a high elastase activity. Okay.
Yes.
Okay.
And please note, macrophages and neutrophils, they have different type of elastases. Okay.
Okay.
And only the neutrophil elastases will be inhibited by the alpha-1 antitrypsin. While the metalloproteinases, if you guys remember,
Yes.
metalloproteinases, right? So the metalloproteinase inhibitor will inhibit the macrophages elastases. Okay, so two type of elastase, one which is released by the neutrophils and second which is released by the macrophages. Only the neutrophil elastases will be inhibited by the alpha-1 antitrypsin, while the macrophages elastases will be inhibited by the inhibitors of metalloproteinases. Okay.
Yes.
So when this alpha-1 antitrypsin deficiency occurs, what you will have is the high neutrophil number. Okay, you will have an activity of elastasis which is released by the neutrophils, not by the macrophages. Okay.
Right.
It is again an important thing that you must remember. And what you will find on the sputum analysis in the patient? You will check for the sputum also, right? Yeah. You will check, of course, when you check the sputum of the patient, what you will see is the neutrophils, CD8, macrophages again, right?
Yeah.
And when you see the increased number of these cells, you will immediately know that the patient must be having a COPD, this emphysema. Okay, so that's, I think, everything about the emphysema. And whenever you encounter a patient having an acute attack of the COPD, the important thing you will give the patient is a beta agonist, right? Because you need to dilate the airways,
Yes.
right? So this is an acute treatment you will give to the patient. For the chronic treatment, long-acting beta agonist could be given, or maybe the muscarinic antagonists can also be given, right? Ipratropium, tiotropium bromide, remember?
Yes.
So these are the again agents which could be given for a COPD chronically. Any doubt?
No, thank you.
Okay. And please note, you won't have cyanosis in case of emphysema. Okay, so these patients are known as the pink puffers. If you encounter a patient having a history of smoking and cyanosis, that means patient must be having a bronchitis, not the emphysema. If you encounter a patient with no cyanosis, having a history of smoking, that means the patient will be emphysemic. Okay.
Yes.
So that was about it. Now the third type, which is the asthma. In the asthma, it is a type 1 hypersensitivity reaction. Okay. So what happens is, due to certain allergens that are entering in your lung, okay, first of all, you will be having an activation of IgE. Okay. So see, what happens is, on the first time when you encounter these pollens maybe or some kind of an antigen in your lung, okay, you will be having an activation of antigen presenting cells, right?
Yes.
Now these antigen presenting cells will present the antigen to the CD4 cells. And I told you these are the CD4 cells which will decide what kind of an inflammation should be given in this scenario, right?
Right.
They're kind of a manager of the inflammation. So when the CD4 cells got activated, they will secrete a large amount of interleukins that causes the release of IgE antibodies. And what is the interleukin that causes release of IgE antibody?
5.
5 will cause the IgA and eosinophils, not the IgE.
Interleukin 4, I think.
Interleukin 4. Interleukin 4 for the IgE and IgG. Okay. So these CD4 cells, they will release large amount of interleukin 4. Okay. And this interleukin 4 will cause a release of IgE antibodies. Now these IgE antibodies will activate the mast cells. Okay. They will attach to the mast cells. And now these mast cells are waiting for this antigen next time. Okay. They're present in the lungs and they're waiting for the antigen. Next time when you encounter this antigen again, the mast cells will be activated because these IgE are present there. Okay, these all these antigens will be attached to the IgE antibodies and they will cause a degranulation of the mast cells, right? Now these mast cells will release all these granules, okay, that this histamine and this tryptase and other things that will cause the bronchospasm, and that is the immediate thing will happen in case of asthmatic attack. Whenever the patient encounters these antigens, okay, the patient will have a sudden bronchospasm, right?
Yes.
And because of this bronchospasm, patient will be having a wheezing, trachepnea, dyspnea, hypoxemia. Okay, all these things will happen in an acute attack. Pulsus paradoxicus can also be happen in case of acute attack. Okay, so these things will be present whenever the patient having a acute attack. Now, when this acute attack is over, okay, now after this, all this these inflammatory markers are being released, they will cause the recruitment of the eosinophils. And not just the eosinophils, macrophages, some amount of macrophages, some amount of neutrophils will also be recruited. And now they will cause the tissue damage. And because there's an inflammation, what this patient will have is the cough. Again, more wheezing will be there, right? And all these mucus pluggings and all the things will be there because of inflammation. So first you have only the spasms. So spasmodic symptoms like the wheezing, dyspnea, hypoxemia, trachepnea, pulsus paradoxicus, these things can happen. After this period is over, patient will get this inflammation, right? And now because of the inflammation, patient will have a cough, mucus pluggings, crackles, okay, rhonchitis, and all these things will happen. Okay.
Yes.
So that was about the attacks. So these are the findings you will see whenever you encounter a patient with asthma. In between the attacks, these patients are absolutely normal. If you perform an X-ray in between the attacks, you won't find anything. If you perform the auscultation, you might not find anything in case of this auscultation also. When you perform the spirometry, in the case of asymptomatic patient, when they're not having attack, spirometry could be normal. Okay, so everything will be normal in between the attacks. Only at the time of attack, you will see the X-ray changes. You will see the hyperinflation, just like in case of COPD. You will see the same thing in the asthma also. Okay, you will see all this auscultation changes. That means a wheezing will be present at the time of this attack. Crackles could be present, rhonchitis could be present at the time of attack, right? But in between the attacks, everything is absolutely normal. Okay.
Yes.
Yes.
Now, so if the patient is asymptomatic, he's having a negative X-ray, negative of everything in between the attacks. So how would you confirm whether the patient is having asthma?
Might induce the obstruction.
Yeah.
Inducing the obstruction by beta blocker.
You need to induce the attack of asthma, right?
Yes.
But if you induce an attack, patient can die because of that also, if this attack is kind of prolonged, right?
Yeah.
So you need a short-acting agent that induces a very short attack of the asthma, right?
Yes.
Yes.
And that agent is a methacholine. It is a very short-acting agent. If you see a patient who's having a normal spirometry and you suspect that this patient could be having asthma, okay, so what you will do, you will give the patient methacholine. If you give the patient methacholine and the bronchospasm happens severely, and the patient got asthmatic symptoms, and this spirometry become abnormal immediately after giving this methacholine, that's how you know that the patient has a very sensitive airway passage and the patient is having a bronchospasm after giving the methacholine, and that's how you know patient is having asthma. Okay.
Is that used clinically or just theoretically?
It is used clinically also, I think.
Okay.
Okay, if you see the patient is having everything normal, so the only way which is left for you is to check the patient this methacholine challenge, right? That is the only way remaining, or you have to wait for the attack of the asthma in the patient, right?
Okay.
So that's why this methacholine challenge, because a methacholine is a very short acting agent. You give this, a very low dose is given, that in a normal patient it won't induce anything. But in case of asthmatic patient, because they're having a very sensitive airway passage, you will see a bronchospasm after giving this methacholine. Okay, and that's how you know patient is having asthma. Now, if you encounter a patient having asthma, and you see that the patient is having an abnormal spirometry, but you guys also know, because all of them are obstructive lung diseases, that means in all of these patients, they will be having the same kind of spirometry, right? So how will you differentiate if the patient is having asthma?
History of allergies.
Okay, history of allergy, but sometimes patients don't even know if they're having an allergy.
From the history, diurnal variation.
Okay, any kind of a test you can perform?
Sputum analysis.
Okay, and what you'll find on a sputum analysis?
Those
Is it
charcoal-laden crystals and Kirschmann spirals.
Yeah, but this sputum analysis could be negative in between the episodes again.
eosinophilic cells and sputum?
Yeah,
Immune cells.
eosinophils. See, you can have a high eosinophil count, no doubt, but this high eosinophil count doesn't support a diagnosis of asthma, right? You can have this high level of IG in other cases also, right?
Yes.
So specifically saying that IG is for the asthma is not the thing, right?
Okay.
So IG can be it. Yeah.
The history of attack, if there's a specific trigger that might think that asthma is the result.
Okay, this will cut. Yeah. Okay, this could help you, but the other important thing you will perform, in the examination of the patient is after you perform the spirometry and you got a abnormal kind of a spirometry supporting the diagnosis of obstructive lung disease. After that, you will give the patient levobuterol, which is the beta
Agonist.
agonist or blocker.
Agonist.
Agonist. You will give the patient this agonist, and what you will see is a dilation. You will see a normalization of the symptoms of the patient. Spirometry become again normal. So you give the patient bronchodilator and a small dose of bronchodilator. Okay, and the patient got a normal passage again. That's how you know patient is having a asthma and not a other COPD. Okay.
So the response for beta agonists will be confirmed diagnosis.
Yeah, exactly. You will perform the spirometry. This will make you a suspect. Okay, you will suspect that this patient could be having asthma, could be having a COPD. The only way you can do is to give a patient levobuterol if other findings are negative. Okay.
Okay.
So this is again an important thing. At the time of episodes, chest X-ray and all the things would be present. You will see on the sputum of the patient is having a very high eosinophils, a high IgE levels. Okay. Patient is also having two things. One is the Kirschmann spirals, and second is the charcoal-laden crystals. Because of this inflammation, the respiratory epithelium of these patients can also be damaged, and it will shed. So when the patient coughs, and in this sputum, all this damaged epithelium will shed in it, right? And what you will see is the Kirschmann spirals. Okay, eosinophils, they will form a crystals in their mucus. Okay, and as a result, on their sputum, what you will see is a charcoal-laden crystals. Okay, let me show you. So this is the Kirschmann spirals. They have this spiral shape, as you can see, and this is all the epithelium of the patient respiratory mucosa, right? And this is the charcoal-laden crystals. Okay, they are double hexagonal, as you can see. Okay, or a rhomboid shape maybe. Okay, so that's what you see in case of sputum analysis of the patient having a asthma. Now, DLCO will be normal in between the episodes, but the DLCO will be increased when the patient got an acute attack. Okay. Okay.
Why is it increased?
Why?
Why is it increased?
Because of inflammation, you're having an inflammation in the alveoli also, right? They will be damaging the barrier of their the diffusion barrier, and that is again causing the increase in the DLCO. Only at the time of inflammation. After that, all this mucosa, all this alveoli, endothelium will be healed, right? And that time you will have a normal DLCO.
But I have one question.
Okay, thank you.
Yes.
Increase in DLCO means that carbon monoxide is diffusing more than normal, because in emphysema it's written that DLCO decreases because of those destruction from alveolar, destruction of the alveolar
Let
wall.
me check. There might be some confusion. Let me check. Just give me a second for that.
Okay.
Let me confirm it on the internet. I think it is decreased, not the increased.
I think I saw something on UWorld. They said that DLCO is increased due to increased vascularity and stretching of alveoli, but it's not. I'm not sure.
Let me check this 1 second.
Okay.
Okay, so the DLCO could be normal in these patients if they're having a moderate kind of thing or in between the episodes. If they're having a severe asthma, they can have an increase in the DLCO. Okay. And that happened because of a hyperinflation. Okay. That is what written here. It is because of a hyperinflation. Okay. These DLCO levels could be increased also. Okay.
Okay.
But hyperinflation is seen in all COPDs, right?
Yes, that's written here. The high DLCO values has been explained by the hyperinflation and increase in the intrathoracic pressure. That is what written here. So I guess there might be some other stuffs also present.
Okay.
So DLCO is increased or could be normal in case of asthma, but decrease in case of COPD. Okay. That again could help you in diagnosing whether it is a COPD case or whether it is an asthma case, right? Now, other important thing that you must remember that the patient, whenever the patient give you a CV having a case of asthma, they will always tell you that some kind of exacerbations could be present. Okay. And this could be exercise most oftenly, and could be a cold weather. Okay. So they will tell you the patient, as soon as the winter approaches, he started having this shortness of breath, more often. Or when the patient exercises, the patient started having this shortness of breath. Okay.
Yes.
So these two histories again is very important. Cold weather and exercise, please remember. You will see more cases in case of cold weather and more cases with the exercise. Now, even if the patient is having an asthma attack, okay, he can even have a normal eosinophils. He can have a normal IgE levels also. Okay, but still you will call it a asthma. And can anyone tell me any condition where you have a normal IgE levels, normal eosinophils level, but again having this asthma?
Aspirin-induced asthma.
Aspirin-induced asthma. I told you about the NSAIDs that they inhibit the COX, right? By inhibiting the COX, all of that agonizing metabolites, they will be undergoing into LOX pathway, right?
Yes.
The lipoxygenase pathway. And as a result, they will be increasing the level of leukotrienes, right? And these leukotrienes will causing the vasoconstriction and the bronchoconstriction, remember?
Yes.
So because of this, because of the COX inhibition, in case of NSAIDs, if you give the patient NSAID, they can have a asthmatic attack also because of the bronchospasm. But in that case, you won't find any case of this eosinophils or maybe the IgE in the blood. Okay.
Yes.
So again, remember this case of NSAIDs induced asthma. Okay. Patient can also have a chronic sinusitis, nasal polyps, and asthma along with that. So just know for this also. Okay. And remember this condition where patient have a nasal polyps, asthma, and sinusitis.
Yes.
What is that condition?
Samter's triad.
Yes. So remember all. You don't have to remember that. Okay, no one will ask you this. Just for a knowledge.
What it was? Sorry, I didn't listen it. What's the condition where we have nasal polyp and sinusitis?
Just give me a second. I'm searching something. Just give me a second. I'm missing one more thing here. Okay, no. Yeah, that was about it. The aspirin intolerance, bronchospasms, and the nasal polyps. Yeah, one more thing I'm forgetting to tell you about the occupational asthma. What was your doubt? Someone was asking a doubt, right? What was it?
I just asked about you said about syndrome, have nasal polyp, asthma, and sinusitis together?
Sample tried, right?
Samtra trial?
Yes.
Okay. It's
You
written
don't have
in
to
chat
remember that.
box.
Don't worry. Okay, in the exam they won't ask you this. So just for
Okay.
the knowledge thing, you can remember that. Okay. So
Thank you.
one more important thing that you have to remember is a case of this occupational induced asthma. Okay. What happens is when a patient started a new job, okay, then because of certain environmental these antigens, the patient can have a this asthma thing also. But as soon as he go on a vacation, okay, or maybe changes the job, patient will get a normal symptoms again, normal thing. Okay, they won't have any symptom, they won't have any attack of the asthma. So whenever you see such kind of this presentation, when the patient got a shortness of breath, wheezing, cough, okay, sputum, as soon as he started this job or within 3 months of starting the job, and when he go on the vacation, he won't have any kind of these symptoms, you will immediately know that the patient is having a case of occupational asthma. Okay. So if you encounter a patient having the attacks of asthma in the work palace, okay, in the workplace, but as soon as he go on a vacation or some go away from the job, he don't have any kind of a symptom, you will know that the patient is having a occupational asthma. Okay.
Okay.
That was again important. That was all on this page. Any doubt, please ask.
There's an exercise induced asthma also, right?
If there's an exercise induced asthma also, yes, that happens whenever you do the exercise.
Yes.
Actually, attacks of asthma can happen with the exercise also. I told you, right?
If
You
the
have more
allergic
attacks. Yeah, exactly.
Yeah, it is not like the occupational one.
So any more doubt on the obstructive lung diseases?
No, thank you.
Okay, guys, I have to take a short break of 10 to 15 minutes. Okay, then we'll continue again.
Sure.
Okay. Okay, so let's continue this obstructive lung disease. And next we have is the bronchiectasis. So in the bronchiectasis, you will be having a dilation of the airways, a total dilation because of a chronic inflammation, or you can say a severe inflammation or a recurrent attacks of the inflammation. Okay, you will be having a destruction of all this elastin from the tissue, from the tracts. And as a result, a very high compliance will be there in the lungs, and that will cause a permanent dilation of the airways. And that condition you will call it the bronchiectasis. Okay. Most of the times it will happen because of an infection, and the infection is basically because of the Pseudomonas aeruginosa. Okay, very important, you must remember. Okay, patient will be having a purulent sputum because of that. You're having an inflammation because of an infection, so purulent sputum will be present. Hemoptysis can also happen because of a dilation of these airways. Your bronchial circulation could be destroyed. Okay, and because of a damage to the bronchial vessels, you will be having a life-threatening hemoptysis. The patient can die because of that also. Okay, clubbing can also happen because of a destruction of all these vessels. I told you whenever a destruction happens, you will have a passage of macrophages, right? Sorry, not the macrophages, but the megakaryocytes, right?
Right.
And these megakaryocytes will enter to your peripheral tissues, causing the clubbing there. Okay. Now, pathology because of a chronic necrotizing infection, or of the bronchi, or maybe due to this obstruction, patient will be having a permanent dilation of the airways. DLCO of the patient will be normal in this case because the alveoli is quite normal. You're just having a dilation of the airways, right?
Right.
So whenever you have a bronchial obstruction, any kind of, okay, whenever you have a poor ciliary functions, that can happen in the smoking in case of COPD, right? If you're having a cardiac syndrome, cystic fibrosis, okay, if you're having a allergic bronchopulmonary aspergillosis, remember this condition?
Yes.
And what does happen in this allergic bronchopulmonary aspergillosis?
Allergy against this aspergillus infection.
Okay, you will have a recurrent infections of the aspergillus, or maybe a recurrent colonization with this aspergillus. With this recurrent colonization, you will be having a recurrent episodes of the inflammation, just like the asthma. Patient will get a repeated episodes of the this acute onset of asthma, and as a result, finally, patient after years later have a permanent dilation of the airways. So this allergic bronchopulmonary aspergillosis can happen in asthma. Okay, it happen in 10% of the asthmatics patient. Okay, so whenever you see this condition, it will always be in a asthma patient. Okay.
Yes.
So if you encounter a patient having a recurrent episodes of asthma and now he's having a permanent dilation of the airways, that means a bronchiectasis, step one will ask you what could be the cause behind it. It will be the allergic bronchopulmonary aspergillosis. Okay.
Yes.
Now, because this is an allergic condition, you will see the eosinophils again. Okay, you will find the eosinophils in the sputum of the patient. So if you encounter a patient having a very purulent sputum, having a chronic history of inflammation in the lungs, could be asthma, could be COPD, could be a patient having a cardiac syndrome, could be a cystic fibrosis patient. Okay, if you encounter such kind of a patient having a purulent sputum, having a clubbing cyanosis, you will immediately think about the bronchiectasis. You perform the X-ray of the patient, you will see the very dilation of the airways. Not the X-ray, sorry. You perform the CT on the patient. On the CT examination, you will see the patient having a very dilated airways. On the gross examination, you can see all these dilations will be present in the lungs. See, all these dilations will be present, right?
Yes.
So this thing will be found on the bronchiectasis. Again, because they might be causing by the COPD. So what you will find is the hyperinflation, right? Again, okay. So if you encounter a patient having a worsening cough, thickened sputum, shortness of the breath, a purulent sputum, okay, or other findings of the COPD could be there, you will think about the bronchiectasis. Okay, lung crackles could be there, rhonchi could be there, and you guys know why the crackles and rhonchi are happening, right?
Yes.
And other thing step one can do is that they can ask you why in case of cystic fibrosis you're having bronchiectasis. So this is because of a recurrent infections by Staphylococcus aureus in case of child, and Pseudomonas aeruginosa infection in case of adult. Okay.
Yes.
Because you guys know that in case of cystic fibrosis, you'll be having a blockage in the airways, right? Because of a thick mucus or dry mucus.
Yes.
And this thick mucus or dry mucus, it will block your passage. And because of this blockage, you will be having a recurrent infections with the Staphylococcus aureus, and that can cause the bronchiectasis ultimately because of a recurrent inflammation. Okay. And step one can also ask you why the hemoptysis is happening. It is because of a damage to the bronchial vessels. Okay.
Okay.
And that's why this hemoptysis could be life-threatening to the patient. The patient can die because of that condition also. Now, any doubt on this bronchiectasis?
No, thank you.
Okay, so we are done with the obstructive lung diseases. Now, any doubt anywhere on this obstructive lung diseases, please ask.
No, thank you.
Okay, let's discuss the restricted lung diseases. In the restricted lung diseases, your lungs are not expanding. There's a restriction in the expansion of the lungs. It could be due to a mechanical causes or external forces. It could be due to a damage to the lungs also directly. Okay. The extrapulmonary causes includes whenever you have a poor muscular effort. For example, if you encounter a patient with a polio, okay, in case of polio, you will be having a lower motor neuron palsy, right? Right? Remember?
Yeah.
So polio, again, the myasthenia gravis can happen because of that condition also, because you're having a very poor muscle function, right? You're having a very weakening of the muscles, and you require the muscle, you require the diaphragm, you require the extrapulmonary muscles in order to get a respiration, right? Inspiration. So with the help, in the condition of this myasthenia gravis, patient will have a very weakening of the muscles, so the lungs cannot expand. Patient will get a restricted lung disease again, right?
Right.
An acute phenomena can happen if the patient got a Guillain-Barré syndrome. Remember, a very acute onset of respiratory failure you will get in this condition, right?
Yes.
And that's why you need to put the patient on the ventilator for like a month even, until the patient has a improvement in his condition, right?
Yes.
So these three important causes for the poor muscular effort. Now, second one, patient can also have a scoliosis. This is scoliosis, okay, where the patient will be having a very abnormal curvature of the spine, right?
Right.
So this scoliosis can also cause the poor expansion of the lungs. If the patient is having a obesity, okay, if the patient is having a very severe or a morbid obesity, in that case, this obesity, this fat will also prevent the expansion of the lungs. And if you guys go back to the physiology, we have discussed the causes of hypoxemia in which the patient is having a normal AA gradient, remember? And one of them was the obesity hypoventilation syndrome.
Yes.
So because of this obesity, patient is having a very excessive weight over the chest, and this will prevent the expansion of the lungs. So in all the causes, the lungs are totally normal. It's just the extrapulmonary tissues are causing damage to them, right? Or some kind of a this problem in the lungs, right?
Yes.
So in all the conditions, because lungs are totally normal, you will be having a normal DLCO, and you will be having a normal AA gradient, right?
Right.
Because in the alveoli you cannot inspire the air more. So if less air is present in the alveoli, you will be having a hypoxia. That means a less air in the arteries, and as a result, a normal AA gradient will be there. Okay.
Yeah.
Now for the next types, that means the interstitial lung diseases. That means you're directly having a damage to the lungs by any cause. In all of them, mainly you will be having a fibrosis ultimately because of a chronic damage. You will be ultimately having a fibrosis, and a very characteristic thing that you will see on the auscultation is the fine crackles. If the step one mentioned a coarse crackle or a normal crackle, think about the think about the obstructive lung disease. But if the vignette specifically mentioned the patient is having a fine crackles on the auscultation, then doesn't matter what the history of the patient is, doesn't matter what the symptoms are. If you see this buzzword, you will immediately think about the interstitial lung diseases. Is that okay?
Yes.
So fine crackles is kind of a buzzword you will see. Now, in case of interstitial lung diseases, you will be having a damage to this epithelium of the respiratory pathways, or you will be having a damage to the diffusion membranes. And as a result, what you will have is a loss of DLCO and an increase in the AA gradient. Okay.
Yes.
So these two things will always be there in case of interstitial lung disease. The first one is the pneumoconiosis. And I told you the pathology behind this disease. So you'll be having a passage of this fine particulate matter to the alveoli, and as a result, the macrophages will be activating against it, causing a fibrosis, right?
Right.
So in case of cold worker pneumoconiosis, silicosis, asbestosis, or other causes, ultimately you'll be having the passage of all these fine matters in the lungs, in the alveoli, and macrophages will be causing the fibrosis. And because of the fibrosis, you will be having a loss of DLCO, loss of alveoli, and increase in the AA gradient, right?
Yes.
Second one is the sarcoidosis, in which you're having a granulomas in the lungs. Because of this granulomas, you will be having a damage just like in case of tuberculosis. Okay.
Yes.
You will have the cavity lesion, just like a TB. You will be having a lymphadenopathy just like a TB, but here the lymphadenopathy is bilateral. Okay, and the granulomas are non-caseating type. Okay, on the blood levels, you will have to check the level of ACE, angiotensin converting enzyme. You will find a high level of this enzyme there. High level of calcium could be there, or hypocalcemia can also occur. Okay, mostly you will find the hypercalcemia because in this case you'll be having a release of, remember, 1-alpha hydroxylase.
Yeah.
That will be activating the vitamin D3, and this will cause a reabsorption of calcium. So high level of calcium, high level of ACE will be there in these patients also, right? So that's about the sarcoidosis. If you encounter a patient having a cavity lesion on the chest X-ray showing a bilateral lymphadenopathy, having this interstitial lung disease symptoms, that means shortness of breath, and a very rapid respiratory rate, and all these things, you will think about the sarcoidosis. Other findings can also be seen. We will discuss later. Don't worry. Extrapulmonary findings of the sarcoidosis are also there. Okay, because it can include any system or any tissue, right?
Right.
So just like my, the SLE, remember, you can have any finding in this sarcoidosis also. Now, another one, important one, is the idiopathic pulmonary fibrosis. Now, what happens is, because of a damage to your lungs by anything, by any particulate matter, by smoking, or because of anything, the healing is happening improperly. Okay. So in case of my idiopathic pulmonary fibrosis, the damage is happening, but the healing is happening a very improper way. Okay. See, whenever you have a damage to these alveoli, the type 1 pneumocytes, the type 2 pneumocytes will proliferate, right? And they will try to replace these type 1 pneumocytes, right?
Yes.
Apart from that, the type 2 pneumocytes will also activate all these growth factors like the TGF beta, VEGF, fibroblast growth factor, right, to promote the healing. Okay, now in case of my interstitial lung disease, in case of this idiopathic pulmonary fibrosis, what happens is that these type 2 pneumocytes will become hyperactivated and they're not converting into the type 1 pneumocytes. Because of this chronic activation of the type 2 pneumocytes, they will be activating TGF beta, VEGF, fibroblast growth factor, that is causing the fibrosis in the lungs. And you will be losing all your type 1 pneumocytes. So if you perform the biopsy of the patient, what you will find is a lot of type 2 pneumocytes, but a damage in the type 1 pneumocytes. You will be having a deposition of collagen everywhere. Okay. And yeah, so that's the thing you will see on the histology. Other thing is very important that you will see is the lymphocytic type inflammation. Because it's a chronic inflammation, you will see the lymphocytes on the biopsy of the patient. Okay. And this kind of inflammation, it happens in a patchy areas. So you will see some areas which are having a normal thing, okay, normal parenchyma, while some areas are present that are having the fibrosis, as you can see, right?
Yes.
And that gives lungs a honeycomb appearance. Okay, some areas normal, some areas fibrosed. On the periphery mainly, you're having a more inflammation at the periphery than the center. So on the periphery of the CT of the patient, you will see this kind of a honeycomb-like appearance. Okay, all this fibrosis with some normal areas will be seen. Because of this traction bronchiectasis, patient will also be having a dilated airways, as you can see. All of these dilation of the airways are present, right?
Yes.
So two things, fibrosis, alternate areas of fibrosis and inflammation, and alternate areas of normal parenchyma where no inflammation, no fibrosis is there. You will be having a dilation of the airways. These are the three things you will see in case of the patient CT examination or the biopsy, right? Alternating areas of inflammation, having lymphocytes, and alternating areas of normal parenchyma, right?
Yes.
Patient again will be having a dyspnea, clubbing, fine crackles, and a non-productive cough. Again, a pathognomonic thing. If you're having a productive cough, think about the obstructive lung diseases. If you're having a dry cough, think about the restrictive lung diseases, okay?
Yes.
So what could be the treatment to this idiopathic pulmonary fibrosis? The treatment is to inhibit the TGF beta, right?
Yes.
Because if you guys go back to general pathology, wound healing part, this part, we have discussed that TGF beta can cause an excessive deposition of the collagen if it remain active, right?
Yeah.
Not everyone agreeing, I think. Is that okay for everyone?
Yes,
Hmm.
doctor.
Yeah.
Okay. So because of this high activity of TGF beta, patient is having a fibrosis. So the treatment you could give is to inhibit the TGF beta in the patient. Okay. Or
Right.
because they are all the growth factors. So you can give a patient growth factor inhibitors, and these are the tyrosine kinase inhibitors, right?
Yeah.
So these are the other therapies you can give to the patient to the idiopathic pulmonary fibrosis. So whenever you encounter a patient having a symptoms of the respiratory lung diseases, like this non-protective cough, dyspnea, clubbing, fine crackles, and other things, you perform a CT on the patient. On the CT, you find alternating areas of normal parenchyma and alternating areas of fibrosis. You took a biopsy of the patient from this periphery region. You find that at the areas where the fibrosis is present, inflammation was there, lymphocytes were there, and the areas where the normal parenchyma is present, no inflammation was there. You will immediately know that the patient is having idiopathic pulmonary fibrosis. Low count of type 1 pneumocytes and a very high count of type 2 pneumocytes is seen. Okay.
Yes.
So that was about the idiopathic pulmonary fibrosis. Any doubt, please ask.
No, thank you.
Now, because this condition is very peripheral, which is near the pleura, right?
Yeah.
Sometimes step 1 vignette can also tell you the patient is having a subpleural lesions or nodules or a subpleural fibrosis. So when they mention that, that means they're referring to you for the idiopathic pulmonary fibrosis. But if they tell you patient is having a pleural plaques or a pleural fibrosis, that means this is a case of asbestosis. Okay. So don't get confused between a subpleural lesions and a pleural lesions. Subpleural means just on the periphery of the lungs. Pleural means within the pleura. Okay.
Okay.
So the other thing that you must look for is the pleural plaques or a subpleural plaques. So that was about the idiopathic pulmonary fibrosis. Any doubt now? Please ask.
No, thank you.
The other thing is the granulomatosis with polyangiitis. I told you in this condition what will be happening.
Lung involvement, upper respiratory tract involvement, and kidney involvement.
Yeah, you will be having a lung involvement, upper respiratory tract involvement, and the kidney involvement. In the lungs, you will be having a damage to the vessels as well as to the parenchyma. In case of parenchyma, you will be having a fibrosis. In case of vessels, they will be damaging because of the inflammation, right? So cavitary lesion could also be there, or a fibrosis can also be happened. Remember?
Right.
So the fibrosis can happen, and you will get a granulomatosis. The granulomatotic this inflammation in the patients. Okay, along with the inflammation in the arteries. Okay, so that's how you know the patient is having a vaginismus. And upper respiratory tract are most commonly involved. So a history of URTI is always very important. It should always be there in case of vaginismus. Okay.
Yes.
Other thing is the pulmonary Langerhans cells histiocytosis. Okay. In this case, you will be having a eosinophilic granulomas in the lungs. Okay. And again, these granulomas are there. They will cause a fibrosis. You will see the restricted lung disease. So if you encounter a patient having a restricted lung disease with high eosinophil count or having a granulomas in the lungs with the eosinophils, you will think about the pulmonary Langerhans histiocytosis. Okay.
Yes.
The other one is the hypersensitivity pneumonitis. Now, this is important. It is a kind of type 3 and a type 4 hypersensitivity. It happens due to any kind of allergen. It could be a bird. It could be, any kind of a farm dust. Okay. It could be anything. Okay. Now, these particulate matter will be entering into your alveoli and causing an inflammation there. And that is the hypersensitive pneumonitis. Patient again will be having a dyspnea, cough, and cough must be non-productive type, right?
Right.
Because that is a hallmark feature of respiratory lung disease. A dry cough or a non-productive cough will be there. Chest tightness, again, because they cannot expand their lungs, they will be having a chest tightness. Fever will be there. Fever is very important. In all of these conditions, except the sarcoidosis, you won't have the fever, right?
Right.
But in case of this hypersensitive pneumonitis, you will be having a fever also. Okay. Headache is other very important symptoms. So if you're having a lung symptoms along with fever and headache, you can think about the hypersensitivity and pneumonitis. Now, if you perform the bronchoalveolar lavage of the patient or you do the sputum analysis, what you will find is the CD8 dominant cells. Please note, although they're having a lymphocytes, and these lymphocytes are mainly CD8 type, just like the COPD. Remember?
Yes.
So again, in case of hypersensitive pneumonitis, CD8 dominant cells will be there. You perform the chest X-ray of the patient. What you will find is the diffuse reticular opacities and the fibrosis. Well, these diffuse reticular opacities and fibrosis can be seen in any of these things. Okay.
Yeah.
Opacities just means you're having a collapse. You're having a damage to the alveoli. You're having some kind of a solid thing present in the lungs. Fibrosis, and again, these things will be seen in the X-ray. And with any of this disease, you will find the same thing. So again, significance, whenever you see the diffuse reticular opacities and fibrosis, you will know that the patient is having a resting lung disease. Again, then you perform the lung biopsy. On the lung biopsy, you will see the lymphocytic infiltration and importantly, pathognomonic, poorly formed, non-caseating granulomas. So if a complete granuloma is present, because see, lymphocytes can also be seen in case of sarcoidosis, right? And granulomas can also be seen in case of sarcoidosis, right?
Right.
But in case of my sarcoidosis, complete granulomas will be there. And in case of my this hypersensitive pneumonitis, incomplete granulomas will be there. Okay, or a poorly formed granulomas will be there. Okay, interstitial fibrosis can be happening just like with any other disease here listed. You'll be having an interstitial fibrosis that you will see on the histology of the patient. Okay. Now, in case of sarcoidosis, you can have a granulomas. In case of fungal infection, you can have a lymphocytes, right? Also. Okay. So fungal infections can have a lymphocytes. Sarcoidosis can have a lymphocytes. TB can have a lymphocytes. Lymphoma can have a lymphocytes. Interstitial lung diseases can also have, this idiopathic pulmonary fibrosis can also have a lymphocytes. But again, if you find a poorly formed granulomas, that means they're referring to you for the hypersensitive pneumonitis. If you see no granuloma, just the lymphocytes and the fibrosis, you can think about the idiopathic pulmonary fibrosis. If you find a granulomas, which is caseating type, you will think about the tuberculosis. If you find many these plasma cells, B lymphocytes in the lymph nodes, you can think about the lymphoma. Okay, if you see the granulomas again, which are caseating type, along with the lymphocytes, you can think about the fungal infections, right?
Yes.
So different diseases, different features of the lymphocytes will be present. Okay. Now on the sputum analysis, the CD8 cells will be there. IgE cells could be there also. Okay. And IgG will also be increased in these patients. Okay. And yeah, that's about this hypersensitive pneumonitis. Any doubt, please ask.
No, thank you.
Okay, finally you have some drug toxicities. And if you guys remember, all of these drugs that can cause a fibrosis in the lungs, bleomycin, busulfan, remember, 2Bs for the lungs.
Yes.
Amiodarone, which is a
Antiarrhythmic class 3.
antiarrhythmic, it is an iodine-containing agent, can cause a pulmonary fibrosis. Methotrexate can also cause a pulmonary fibrosis, right?
Yes.
So again, same chest X-ray findings, you will see diffuse reticular opacities with fibrosis in all of these conditions. Lung biopsy will help you determining in case of a specific thing, or the bronchoalveolar lavage, or maybe the sputum analysis. If there is present, you can find. Sorry, sputum analysis won't present, right? Because these patients, they don't have the sputum, right?
Right.
Sorry, I misplaced this. You cannot have the sputum analysis in these patients because they do not have a sputum at all. So you only have to perform the bronchoalveolar lavage in these conditions, right?
Yes.
So you will perform this finding, you will see, and that's how you will say what specific disorder patient is having. Now, any doubt?
No, thank you.
In all of these conditions, patient will be having a short, shallow breathing. Okay, shallow breathing with a very high respiratory rate will be present in these patients, right?
Yeah.
So, any doubt anywhere on this page?
No, thank you.
Okay, so let's again repeat that concept that we have discussed about the all the resistance. I told you two type of resistance. One is a elastic recoil and second is the air resistance, right?
Right.
Whenever you have a high flow rate, that means a high respiratory rate, you will be having a more this air resistance, right?
Right.
So as you can see, if my respiratory rate is increasing, okay, and this is my airflow resistance, you can see that with increase in the respiratory rate, the airflow resistance is also increasing, right?
Right.
Similarly, I have second type, which is elastic recoil. Okay, if I have more fibrosis, okay, in that case, I will have more of this elastic recoil.
Right.
Yes, that means more resistance again,
Yes.
right? Now see, with the increase in the respiratory rate, or you can say with the shallow breathing, patient will be having a loss of elastic recoil with a shallow breathing. Okay, a point is reached where the patient's airflow graph and the elastic recoil graph intersects. Okay, and that give you the minimum value of these two. Okay, a combined minimum value of these two. As you can see, with the increase in respiratory rate and with change in the depth of breathing, you will be attain a minimum level where the resistance offered by both of these two combined is minimum, right? And at that point, a normal patient's lung is working, which is around 15, for example, right?
Right.
Now, this is the work of breathing, the work that lungs has to do against these resistance. In a patient who is having a restricted lung disease, these patients will be having a very high workload, of course. Okay, the work of breathing is absolutely increased in these patients. But again, because they're having a fibrosis, if they have a more of this respiratory rate, they will have more airflow resistance, right?
Yeah.
Sorry, elastic resistance. I'm sorry about that. Elastic resistance, right?
Yeah. Yeah.
Secondly, the airflow resistance is not a problem for that, for these patients. As you can see, the graph is very steeper for them, right? The slope of the graph is very low in case of myasthenic lung disease. So airflow resistance is not a problem, but the elastic resistance is a problem for them. As you can see, at a low respiratory rate, or you can say at a very deep breathing, this is a deep breathing, this is shallow breathing, okay? At the deep breathing, patient is having a very high elastic resistance, right?
Right.
So the only way by which they can have a very minimal work of, although the work of breathing is increased, but again, if they want to achieve a minimum level, that could be achieved if the patient is having a high respiratory rate with a shallow breathing, right?
Right.
That's absolutely what happened in these patients. Whenever you encounter such patients, you will see the patients having a very high respiratory rate with a shallow and rapid breathing. Okay.
Yeah.
Now, for the obstructive lung diseases, airflow resistance is a problem for them. With a slight increase in the respiratory rate, airflow resistance, as you can see, increases very rapidly, right?
Right.
But the elastic resistance is not a problem for them. As you can see, elastic resistance is very low, right? So
Yes.
again, these patients will have a very low respiratory rate, but a very deep breathing, because elasticity is not a problem for these patients. So deep breathing with a very slow this rate, right?
Right.
So that kind of a breathing you will see in case of obstructive lung diseases. Although the work of breathing has already been increased, but the body will still try to figure out the minimum workload, right?
Yes.
So that's about this graph. Any doubt, please ask.
No, thank you.
These are the features of the emphysema, which we have discussed already. Now let's discuss about the myasthenia gravis. Now, in case of myasthenia gravis, I told you the nerves are totally normal, right? It's just our nerves, when they're releasing all this neurotransmitter, muscles are not responding to them, right?
Right.
So if you see a patient with having a myasthenia gravis, when they uses the muscle, when they initiate the use of muscle, it would be absolutely normal for them to use. But with that time, because all of the receptors are being degraded, okay, as they continue the use of this muscle, they will be having a weakness in the muscle, right?
Right.
Exactly what happens in case of myasthenia gravis in case of this this aspiration. Initially, they have a normal respiration, they have a normal intrapleural pressure, but as they progresses, they will be having a very shallow respirations, right? As you can see, the intrapleural pressure is decreasing, and that happens as long as they uses the muscles. They will be having a weakness of the muscles, right, with the use. Yes.
Right. Yeah.
But again, important thing, phrenic nerve activity will be absolutely normal in these patients, because I told you nerves was normal. See, the nerve activity is continuous, right?
Yes.
It just in response to these nerves, the muscles are not contracting, and as a result, patient is not having a respiration. So this kind of a graph, you will see if the patient is having a myasthenia gravis. Okay.
Yes.
If there is a defect in the nerve pathway, in that case, the muscles will be normal. So the patient, when they don't have the activity of the nerve, patient won't have a contraction, you won't have a change in the intrapleural pressure. When the patient has an activity of the nerve, you will see the patient is having a change in the intrapleural pressure, right? And if you guys remember about the Cheyne-Stokes respiration,
Yes.
that will happen in case of any herniation or a heart failure, remember?
Right.
In that case, your respiratory center is not responding, and as a result, you won't have an activity in this phrenic nerve at all. And
Right.
that is what causing the bradypnea in the patient, or this apnea in the patient, right?
Yes.
In case of my obesity hyperventilation syndrome, again, the nerves will be absolutely normal. Muscles will be absolutely normal. So again, if I want to draw the graph, the nerves will be normal. Okay, muscle contractions, you will see that the muscle contractions are present. Let this graph representing the muscle contractions. So muscle contractions will be there. But even in presence of the muscle contraction, patient will get a complete apnea after after a few seconds, right?
Right.
And again, when the patient got an apnea, he will again woke up, and the realizes that the patient having an apnea, they again start breathing. Same cycle again repeats. Patient will be having an intrapleural pressure normal, then decreasing, and finally episode of apnea will again occur. But the muscle efforts will be continuous, right?
Yes.
So that is about the graph. You need to remember what is they are asked, what is that thing they are showing. They are showing you the nerve activity and the lung activity, or they are showing you a muscle activity or the lung activity. Okay, so that's how you will have to check if the patient is having a myasthenia gravis, or maybe the obesity hyperventilation syndrome, or maybe the this apnea. Any doubt?
No, thank you.
That was about the idiopathic pulmonary diseases or the fibrosis we have discussed. A damage of type 1 pneumocite, that type 2 will try to try to replace these cells, undergoing the hyperplasia, but ultimately it will be a disordered healing. Patient will be having a high activity of growth factors like the TGF beta, VEGF, fibroblast growth factor. The TGF beta, you guys already know, it causes a fibrosis. So again, in the lungs, because of the TGF beta, you will be having a fibrosis. So the treatment is directed to inhibit these things. Symptoms: non-protective cough, dyspnea, clubbing, crackles, fine crackles, right? Imagine you will see the honeycomb pattern on the CT of the patient, on the chest X-ray, just like with any other case of interstitial lung disease, you will see the reticular opacities, where you will see the fibrosis also, right, on the chest X-ray, right?
Yes.
On the histology, you will see the lymphocytes, but lymphocytes without any kind of this granuloma formations, right? And again, you will see the subpleural lesions, subpleural plaques, subpleural fibrosis, but not the pleural fibrosis. If there is a pleural fibrosis, it means it is asbestosis, right?
Yes.
The other important one is the cryptogenic organizing pneumonia, or you call it a BOOP. Remember the bronchiolitis obliterans? We have studied at one more place also, the same thing. The lung transplant. Remember, in case of a chronic lung transplant, you will be having a fibrosis in the smaller airways that is causing the bronchiolitis obliterans.
Yes.
Remember? Now, same things can also be happen when you got a chronic inflammation in the lung. and it would be a diffuse inflammation. That means it will be involving my bronchioles, my interstitium, as well as my alveoli. Okay, so whenever an inflammation involving all these three structures, okay, and a chronic inflammation occurs, that means a healing will be occur ultimately by the fibrosis. So a diffuse fibrosis will be there in the lung, right, involving all the tracts, interstitium, as well as the alveoli.
You're right.
You will call it a BOOP, or a bronchiolitis obliterans organizing pneumonia. Versus in case of idiopathic lung diseases, in case of idiopathic pulmonary fibrosis, it will be a interstitial inflammation only, right? Without any alveoli involvement, without any this airway involvement, right?
Yes.
So that's again, you will have to identify whether it is a case of interstitial lung disease or this idiopathic pulmonary fibrosis, or whether it is a BOOP. So seeing this thing, whether all the structures are involved or just this pancreas is involved, you will know, right? Just give me a second. Sorry about the interruption. Okay, see, in case of BOOP, what is happening? You will be having a diffuse inflammation in the lung, and a disordered healing will happen, and ultimately you will end up having a diffuse fibrosis in the lungs. Okay, versus in case of your this idiopathic pulmonary fibrosis, you're only having an inflammation and this fibrosis in the interstitium, right?
Right.
So again, that's how it differs from this kind of this idiopathic pulmonary fibrosis. So you call it a cryptogenic because the case, you don't have any specific cause for that. Okay, it is always idiopathic, and that's why the name cryptogenic. It is organizing. That means you're having a fibrosis. Ultimately, healing with the fibrosis will happen. That's why the name organizing. And you're having a pneumonia. That means inflammation in the lungs, right? A diffuse inflammation.
Yes.
Okay. And most of the times, an unresolved pneumonia can even cause this condition. You got a pneumonia, but you're not having a good this healing in the lungs, and ultimately you will end up having a cryptogenic organizing pneumonia. Okay.
Yes.
So because it is an inflammatory process, okay, you will always have a fever in this case. Okay. So in case of interstitial lung diseases, only in two areas you can have a fever. One is the hypersensitive pneumonitis, and second is the BOOP, right?
Right.
So fever will be there, malaise will be there, or that means all the signs and symptoms of inflammation will be there, right? Patient will be having, positive things of the inflammation, but in case of the interstitial lung disease, you won't have any inflammation, right? If diffuse systemic inflammation won't be there, right?
Right.
So again, these findings, having a fever and fatigue, will help you determining difference between the BOOP and the interstitial lung disease or the idiopathic pulmonary fibrosis. Okay, fibrosis will happen throughout the lung. Okay, versus in case of your this idiopathic pulmonary fibrosis, that means in that case only you will have an interstitial inflammation and the fibrosis. Versus if you got a case of ARDS, I told you guys also know that in case of ARDS, patient afterwards can have a fibrosis also, right?
Right.
But a very specific feature of the ARDS is the presence of hyaline membranes.
Yes.
Which you will see that later, don't worry. Okay, so again, a differentiating feature between the BOOP and the ARDS is the presence of hyaline membrane in case of ARDS, and a diffuse fibrosis, that means throughout the lungs in case of BOOP. So patient will be having a dry cough, fine crackles, shortness of breath, loss of pulmonary function test, loss of DLCO. That means all the features of a restricted lung disease will be present, right? But when you perform the biopsy, you perform the X-ray, you perform the CT of the patient, what you will see is a diffuse fibrosis and a diffuse inflammation. Okay. Now, fever can also be there in case of your this hypersensitive pneumonitis, right?
Right.
But this condition is always kind of acute. Okay, you will have the patient of BOOP presenting to you within less than 2 months of the symptom. So you generally have a shortness of breath for less than 2 months, cough for less than 2 months, and all of these symptoms for less than 2 months. Versus in case of any interstitial lung disease, okay, or in case of idiopathic pulmonary fibrosis, in case of hypersensitive pneumonitis, patient can have a more prolonged history. Okay, more than 6 months could be there, right?
Yes.
So on the chest X-ray, you will find a patchy bilateral infiltrates involving the alveoli, bronchioles, and interstitium. So because it is an inflammatory process, you will give the patient corticosteroids, right?
Yes.
So that's about the BOOP. Any doubt, please ask.
No, thank you.
So let's find a session here, okay?
All right. Yeah.
Okay, it's already 9:45. You
Right.
must have seen. Okay.
Okay.
So
Yes.
we will continue tomorrow with the sarcoidosis, and hopefully we will end this session, all these complete sessions tomorrow.
Yeah.
Okay.
Okay.
Thank you so much.
Thank you so much, everyone.
Okay. Thank you so much.
Thank you so much.
Thank you.
Thank you.